Good afternoon. Welcome everyone to the Senate Committee on Health and Human Services. Madam Secretary, please proceed to call the roll.
Senator Lang. Here. Senator Nguyen. Here. Senator Stone. Here. Senator Titus. Here. Chair Donate.
And I am here. Please mark all members present. Good afternoon, everyone, and welcome to today's meeting on Health and Human Services. Today we have a few bills before us. We have a work session that we will start off today with, and then we will have AB 411, AB 11, AB 206, followed by AB 289. The order that I currently have the bills after work session we're going to hear AB 289 first from Assemblyman Carter. Then we will do AB 11 after that. And then we'll do AB 206 by Assemblywoman Brown May. And then the last bill that we will do today will be AB 411. And so that is the order. So it's 289, 11, 206, 411. And just as a reminder, I can take agenda items out of order depending on how today's meeting goes. For folks that would like to testify in support or opposition or neutral on any of the bills, we ask that public comments be kept to 2 minutes each. And then if you wish to testify, you can sign in at the table at the front. That way we know who's in the room. And with testifying, we ask folks to please turn the microphones on to speak and off to listen. And all those, just as a reminder, that anyone who wishes to receive the copies of the committee's exhibits should go to the Nevada Legislature's website. So we're going to go ahead and proceed to the work session. So again, we have a few items for work session, so we're going to go ahead and begin with that. The first bill that we have for work session is Assembly Bill 24. And so I'll go ahead and turn it over to Ms. Cooper, our policy analyst, to begin.
Destiny Cooper, LCB Research Division for the record. I'm nonpartisan staff, so I cannot advocate for or against any measures you hear before you today. Assembly Bill 24, reprint 1, was heard on April 27, 2023. It adds 2 members to the Committee on Emergency Medical Services. 1 member shall be employed by or serve as a volunteer with a local governmental agency that provides emergency medical services but which is not a part of a firefighting agency or law enforcement agency. The other member shall be employed by or volunteer with an agency, organization, or other operator that provides emergency medical services on tribal land. Thank you.
Thank you so much. Any questions on this bill? The motion for this bill is do pass. Oh, do I have any questions? No? All right. I'll take a motion. We have a motion to do pass from Senator Titus and a second from Vice Chair Nguyen. Any questions or discussion? All those in favor, please say aye. Aye. Any opposed? The motion passes for due pass on AB 24, and I will go ahead and take that floor statement. Moving on to Assembly Bill 40. Ms. Cooper.
Destiny Cooper for the record. Assembly Bill 40, reprint 1, was heard on May 2nd. It authorizes the inclusion of an electronic mail address in an application to a health authority for a permit to operate a food establishment by which the health authority may communicate with the applicant and send any inspection report, form, or other notice. The bill authorizes a health authority to furnish an electronic original food inspection report form after such an inspection and to serve an inspection report form or other written notice on a permit holder by sending the notice to the electronic mail address provided by the permit holder. The exceptions are notices related to the suspension or revocation of permits, which shall not be provided via electronic communication. Thank you.
Thank you, Ms. Cooper. The motion for this one is do pass on AB 40. Do I have a motion?
I move. Second.
We have a motion from Vice Chair Nguyen, second from Senator Stone. Any discussion on the motion or questions? Moving on to the vote. All those in favor, please say aye. Aye. Any opposed? Motion's approved, and I will go ahead and take that floor statement. Moving on to Assembly Bill 116. Ms. Cooper.
Destiny Cooper for the record. Assembly Bill 116 was heard on May 2nd. It requires certain healthcare providers to provide information concerning Down syndrome and referrals for related support services to A, the parent or guardian of a child with Down syndrome, or a person who is pregnant and has received test results indicating the fetus has Down syndrome, if the person wishes to receive such information. The Department of Health and Human Services must maintain a website listing support services available in different areas of the state for people with Down syndrome and parents or guardians of such persons. Thank you.
Thank you, Ms. Cooper. So the motion for this one is to do pass AB 116. Do I have a motion?
I move.
We have a motion from Vice Chair Nguyen. Do we have a second? Second by Senator Titus. Any discussion or questions on the motion? Moving on to the vote, all those in favor, please say aye. Aye. Any opposition? Motion's carried, and I will go ahead and assign that floor statement to our Vice Chair Nguyen. Moving on to Assembly Bill 136, Ms. Cooper.
Destiny Cooper, Assembly Bill 136 was heard on April 27th. It requires an operator of a qualified residential treatment program that provides care and shelter for less than 16 children to obtain a license as a child care institution from the Division of Public and Behavioral Health of the Department of Health and Human Services. Any qualified residential treatment program operating on or before January 1st, 2024 may continue operating without such a license until July 1st, 2024 under certain circumstances. Thank you.
Thank you, Ms. Cooper. The motion for this bill is a do pass. Do I have a motion? We have a motion from Vice Chair Nguyen and a second from Senator Lang. Any questions or discussion on this motion? Seeing none, all those in favor, please say aye. Aye. Any opposed? Motion carries, and I will go ahead and take that floor statement. Moving on to Assembly Bill 215, Ms. Cooper.
Destiny Cooper for the record. Assembly Bill 215 was heard on April 27th. It revises the residency requirements for a person to be eligible for appointment to the Nevada Silver-Haired Legislative Forum by decreasing from 3 years to 1 year the time a person is required to have been a registered voter in the senatorial district of the senator who nominates the person for appointment to the forum. Thank you.
Thank you so much. The motion for this one is do pass. Do I have a motion?
I'd move.
We have a motion from Vice Chair Nguyen and a second from Senator Titus. Any discussion or questions? Moving on to the vote, all those in favor, please say aye. Aye. Any opposition? Motion's carried, and I'll go ahead and assign that floor statement to Senator Lang. And moving on to the last bill, Senate Bill 445. Moving on to Senate Bill 445. Ms. Cooper.
Destiny Cooper for the record. Senate Bill 445 was heard on April 27th. It authorizes the Division of Public and Behavioral Health of the Department of Health and Human Services to use money generated from administrative penalties, fees from the issuance or renewal of a license of certain entities to create and maintain an information system. This system will consist of records of individuals who have completed ambulance attendant, firefighter, or legislative training programs. This bill provides for the revenue from such fees collected by DPBH to be accounted for separately and does not revert to the state general fund at the end of each fiscal year. Thank you.
Thank you so much. The motion for this one is do pass. Do I have a motion? Motion from Vice Chair Nguyen. Do I have a second? Second from Senator Lang. Any discussion or questions? Senator Stone.
Thank you, Mr. Chair. I regret that I can't support this as I believe that the fines collected by regulatory agencies should go into the general fund. I don't want a agency to proactively cite people that they're governing for an effort to boost revenues for whatever purpose of their regulatory board may be pursuing. So for those reasons, I'm going to have to be a no today on SB 445.
Thank you, Senator Stone. Anyone else? All right. Moving on to the vote. All those in favor, please say aye. Aye. Any opposition? We have 2 nays from Senator Stone and Senator Titus. The motion carries, and I will go ahead and take that floor statement. That concludes our work session, so we will now proceed to bill hearings. We are going to start off with AB 289, and we will welcome Assemblyman Max Card to begin when he's ready.
Good morning, Chair Donati. Sorry about that. Really butchered that one right off the bat. And members of the HHS, I'm Max Carter, Assemblyman from District 12. And the bill, Assembly Bill 289, is adding in another classification permissively into the statutes that enable cremation and aquamation. We're adding in natural organic reduction, which is human composting. And to walk us through all of this, hopefully you all get over the ick factor in the next 30 seconds or so. And I'm going to turn this over to Tom here to walk through the bill.
Good afternoon, Chair Donate, Vice Chair Nguyen. I'm going to jump in here really quick. Members of the committee, for the record, Chelsea Capurro here on behalf of Earth. Just want to thank the sponsor for taking on this issue. And as he mentioned, we're going to pass it over to Tom Harries. I just do want to say We have coached him. We went over this in the assembly. If he says Nevada wrong, we've tried. We've tried.
Thanks for that introduction. Hello, Senators. Thank you for the opportunity to to present today. My name is Tom Harries. I'm the founder and CEO of a company called Earth Funeral Group. We are one of the first natural organic reduction providers in the US, currently operational in the Pacific Northwest. My background's been in the funeral industry for the past decade, so I can speak to natural organic reduction quite specifically, but also funeral regulation generally. We're going to present a quick 12-slide presentation today, but it is quick, I promise, which is going to give you an overview of what a natural organic reduction is, the process itself, and why people like this as a process. To begin quickly, I thought it'd be helpful to provide some context. And the context of natural organic reduction is quite simply that existing funeral practice is unsustainable. So you have two primary methods of disposition in the US. You have burial and you have cremation, both of which are harmful to the environment in their own right. So burial is putting all sorts of harmful pollutants into the ground, non-degradable wood, metal, concrete, and embalming fluid, which is just toxic chemical. Also thoroughly impractical to keep putting people into the ground in the context of 330 million deaths nationally over the next 80 years. Cremation then is the primary method of disposition in Nevada, and 83% of Nevadans are currently being cremated. But cremation itself is a fossil fuel driven process that emits CO2 equivalent to a 600-mile car journey. With that said, we're going to start on this quick presentation. So what is natural organic reduction? Natural organic reduction is an environmentally friendly alternative to burial and cremation. So instead of being cremated and turned into ash, you're getting gently transformed into soil. The process takes 45 days, and at the end of the process, you choose how much soil you would like returned as the family. You can keep it, you can scatter it, you can plant it, so much the same as cremated remains and even more. As Earth, we've seen people drive to 10 national parks and scatter it in places meaningful to them, plant orchards, plant memorial gardens, restore fire-damaged lands. So do stuff that is meaningful to them with this soil. Any remaining soil then is then sent to conservation land, where it's been used for wildfire restoration, it's being used for reforestation, and it's been used to generally restore and protect land for future generations. And the soil quite literally serves as a means to return the goodness in our bodies to the natural world. So instead of sort of blasting the nutrients up in smoke, we can return the nutrients to nature. The science behind this process, as Assemblyman Carter says, is composting. Composting is the technical term for an accelerated natural process. So we are doing what would happen on the forest floor, but we are optimizing this through science and technology. So each process takes place in its own individual vessel. You can see a picture of an earth vessel on the side there. And the vessel is controlling temperature, moisture, and oxygen levels. And what that's doing is creating perfect conditions for microbes to break a body down on a molecular level. And the output of which is nutrient-rich soil. So much the same as any soil you'd find at a garden centre or nursery centre. I would challenge you to distinguish between the two. And then just to comment finally, this is a completely natural process. There are no chemicals used as part of this process, and there are no insects used as part of this process. This is purely accelerating and optimizing nature. In terms of the process itself then, it follows a 4-step process. It starts by gently washing a body and wrapping it in a biodegradable shroud. The body is then placed on the vessel, in the vessel that we just saw, on a layer of organic mulch, wood chip, and wildflowers. What that is doing is balancing carbon and nitrogen. And then the body and organic material remain in the vessel for the 45-day process. And as I say, it's microbes that break everything down at a molecular level. At the end of the process, you have soil. You can choose what you want to do with it. Nutrient-rich, life-giving soil. Choose what you want to do with it as a family. And any remaining soil is being sent to conservation land for restoration projects. Final 2 slides, I promise. Why do people want natural organic reduction? Natural organic reduction, quite simply, is a matter of consumer choice. If you want to be buried, you can be buried. If you want to be cremated, you can be cremated. If you want to be gently transformed into soil and returned to a beautiful piece of land, that can happen too. So natural organic reduction is perfect for people who are trying to minimize their carbon footprint. It's perfect for people who like spending time outdoors and in nature. And it's perfect for people who do not resonate with cremation or burial. And it's quite hard to resonate with something like cremation, I think. Finally, key benefits are it's a gentle, natural process. It's net carbon neutral versus 535 pounds of CO2 produced by cremation. It restores and protects land for future generations. And your final resting place is one of iconic beauty. So in Nevada, that could be Lake Tahoe or somewhere similar like that. And I'm going to stop there.
And yes, sir, first off, I want to apologize, Chairman Donyate. Still a little bit scattered from experiencing the City of North Las Vegas bill this morning, but we're back on track. And so I'm carrying this bill because I'm very involved in the trauma and grief world and know personally how that you never know what's going to be that one thing that brings a little bit of light in a very dark period in somebody's life. And also, I want to say that this bill is not narrowly tailored. It is broad, enabling the practice. It is not proprietary in any means at all. And with that, I'll turn it over for questions.
Thank you so much. Appreciate the presentation. I do have a request from my committee members. If you have a question before you ask your question, since we are talking about soil in a particular circumstance, if the question is, if you could be a tree, what kind of tree would you be? So you have to answer that first before you ask them a question.
She's not ready yet. I'm ready.
Okay, Senator Titus.
Maple, because I'm so sweet. All right, so having said that, thank you for bringing the bill forward. We do have other methods. We have the alkaline hydrolysis that we passed that bill in 2017. And I just don't think it ever took off. I mean, I don't see that as a big proponent, so that we do have alternatives. I have a couple questions. Do you reuse the vessels?
Tom Harris, Funeral Group. Just quickly touching upon alkaline hydrolysis, I think that's the reason it hasn't taken off is no one can pronounce it, and it's quite literally dissolving a body in alkali solution and washing it down the sewer. So it's not a particularly...
Well, you still have some bones left over, or you still have some components. It doesn't
Correct.
really break down all the
Correct.
products.
But it's not massively conceptually appealing,
Right.
is what we would say. In answering that, I forgot the actual question. Oh, yeah, the vessel,
Vessels.
yes. The process takes 30 to 45 days, and the vessels are reused.
So it's pretty. So depending on the body size,
Exactly.
that determines how long it takes. And it's all aerobic as opposed to anaerobic because you add oxygen to this.
Yes, this is an aerobic process.
Right. So we do have. I'm a physician. We do have aerobic process. We have anaerobic process, and I assume that by the proper temperature and the proper amount of water,
Yes.
that you allow that to do that natural process.
Yep.
And then it's sealed though, but you have to put oxygen in there for that to work, correct?
Yes.
Okay. Next, can I continue? So a lot of my patients may have a pacemaker. They might have some implantable device, even if it's just a little stent in place. Do you have to remove those before you put the bodies in?
No. Tom Harris, Earth Funeral Group. Sorry, Chelsea is reminding me to follow proper etiquette. Sorry. Any inorganics are removed at the end of the process and are recycled. So they won't biodegrade because they're not organic or biodegradable, but they are removed and recycled at the end of the process.
Can I continue? So 2 other states have this law that's passed, correct?
6 states.
Six
Sorry,
states so
Tom
far?
Harris, Earth Funeral Group. 6 states have passed this process. So Washington was the first state. Colorado is shortly thereafter. I believe Oregon was next, then Vermont, then California, then New York. And there are probably 10 different bills this year as well in a number of other states also. So a lot of momentum, a lot of which has been grassroots driven as well.
Right. And so conceptually, I absolutely support it. I compost all kinds. I rarely throw anything away. I recycle everything I possibly can, and we have a large compost on a little farm type of thing. So it's good. I plan on being cremated and be thrown into my river property, but you can't throw this into Lake Tahoe because I have real strong rules about silt and dirt in Lake Tahoe, just so you don't use that as an analogy on what you do with this stuff. So when you mention whatever the amount that folks don't want to take, do they come and take a scoop and decide what they want? What's that process? And then you mention what's left over you take to a conservation area? Are those designated, or what do you mean by that?
Tom Harris, Earth Funeral Group. Just to clarify the Lake Tahoe point, this would be forest land surrounding the lake, not actually in the lake. The families choose how much soil they'd like returned. So some families take all of it, some families take none of it, and some families take portions. The process produces about ½ cubic yard, which for reference is quite a lot of soil for the average person. So any remaining soil is getting sent to conservation land. That land is currently private land, and it's been used for conservation projects such as reforestation and wildfire restoration and that sort of thing.
Thank you so much. Any other questions? Vice Chair Nguyen.
Thank you, Assemblyman Carter. I'm really excited to, when I heard that you were bringing this bill, I had the opportunity right after the 2019 session to meet Washington State legislator that had brought that legislation that led to that law in
Vice Chair
Washington.
Nguyen, tree.
Tree, oh.
Yeah.
I would use some here locally with the Palo Verde because I like the yellow flowers and it's native and it grows here and it's drought tolerant. And I would probably give some to my dad because he's still trying to grow a dragon fruit in our front yard. Yeah, those are the two plants, I think. So, sorry about that, Chair. I have a question. I've heard all about the haunted forest as well on the conservation. As far as what are the costs for this? I've heard that it's more economical. You know, obviously there's environmental savings, but can you talk about the costs?
Tom Harris, Earth Funeral Group. Yes. So the average cost of a funeral in the US is about $8,000. Earth, as a company, I can't speak for other operators at the moment or in the future, currently charges $5,000 in the Pacific Northwest. We expect that price to come down over time as this becomes more widely adopted and the technology becomes cheaper and we operate at higher volumes, etc. So we will achieve economies of scale in due course and bring the price down. That's the goal.
Thank you so much. Senator Stone.
Thank you, Mr. Chair, and this is no reflection on my ego, but I like the giant sequoias, okay? Thank you for the presentation. It's funny because my wife's family has been in the funeral industry for quite some time. I don't know if you know Ben Price, but he's part of a big corporation that owns mortuaries throughout the country. And we were talking about this very bill, and he had very positive things to say about it. He says, one thing you want to make sure that the families understand that you're not going to be getting your loved one's remains in a small vessel. If you want to take the soil, you're going to be getting a large vessel, and I'm not sure if that vessel that we saw is the one that you're going to be delivering to the family, or if it's some kind of a disposable vessel. If they want to put Grandpa in the backyard, I guess they can put Grandpa in the backyard. But how are you delivering that? And if you don't deliver it, unless somebody says they do want to go into a preserve area, which is nice, I assume that you will give them a location of where Grandpa is going to go or Dad's going to go, and the kids can go visit the site, I guess. So if you could explain that. And also, I think you mentioned it's a 45-day process, right? And are there microbes that you put in there, or is the microbes a part of the fauna, the flora that you have going in there that helps the degradation process? So.
Tom Harris, Earth Funeral Group. I was writing those questions down, so correct me if I get them wrong. But the picture you saw of the vessel is the vessel in which the process takes place. So people are not taking that home. It's way too expensive to be giving away. That is the vessel that is controlling moisture, aeration, and temperature. And it's a 7-foot long, 3-foot diameter vessel. At the end of the process, depending upon how much soil families would like returned, that determines on the size of the container. So about 90% of people are only taking portions home. The portion is similarly sized to cremated remains. They're very similar in size there. If you want larger soil, a larger amount returned, you have to collect it yourself. And people bring appropriate vehicles, etc., to be able to transport that. Moving around big chunks of soil is a logistical endeavor that we have not undertaken ourselves just yet. In terms of forest land, yes, people know where it's going. I think that's one of the things that really resonates with people, is the opportunity for your final resting place to be one of natural beauty. In Washington at the moment, we have a piece of land on the Olympic Peninsula in Washington, and we would do something similar in Nevada as Earth as well, finding an iconic piece of local land. Final question, I think, if I got them all, was around microbes. The microbes are naturally occurring, either within the body or in the organic mulch and that sort of thing. So we are not adding anything additionally. This is pure nature at course.
And then there's just one final question. My colleague, Dr. Titus, mentioned certain prosthetics, titanium things, cardiac devices. Those are not going to obviously decompose, and you mentioned that you're just going to recycle those things, but I guess on a more morbid sense, but one that has value. Do you return gold teeth to the family after the process is done? And I say this kind of interestingly. I was admitted to the USC School of Pharmacy, and I couldn't really afford to go there, but my family pitched in, and I was living with my grandmother, who was widowed for about 7 years, and she gave me my grandfather's drawers, and I went through his drawers and found his dentures. I said, "Grandma, he's been dead for 7 years. Why are you keeping his teeth?" She said, "Oh, it's sentimental, you know." So I threw them away, and I saw this flash, and I see this gold bridge. And I said, "Grandma, do you realize there's a gold bridge here?" And she goes, "Oh, no." I said, "Do you mind if I have it?" She goes, "Really?" "Yeah, I'm going to get a piece of jewelry, and I'm going to have it made. I'm going to wear my grandpa, who I was very close with, for the rest of my life." So I wore it for 40 years, and because I had a wonderful relationship with my grandfather. Edward Friedman was his name, and who always encouraged me to go to school. He didn't have the opportunity to go to school. He was an immigrant from Russia. So when my son got elected to Riverside County Superior Court judge this past year, it was right before the election. He won the primary. And so I took the necklace off, and I said, "It's time for you." He says, "Why are you doing that, Dad?" I said, "Because it's brought me wonderful luck all my life, and I want you to have the good luck that I've had." And he won his election. So anyway, sometimes those little gold pieces mean a lot to a family, and I appreciate to hear that you're going to sift through the remains and give those items back to the family. So anyway, thank you for the presentation. Sorry about the story, but.
Thank you so much. Any other comments before we move on to testimony? Senator Titus.
Just for clarification, that vessel's not a tumbler, correct? It sits in one place, or is it a tumbler?
Tom Harris, Earth Funeral Group. It agitates gently side to side.
Okay, thank you.
Thank you so much. Any other further questions? Let's move on to testimony and support. If you are here in support of this bill, please come forward. And same in Las Vegas. If there's any folks that are like to testify in support, please come forward. We'll start here in Carson City.
Thank you, Mr. Chair, members of the committee. Isaac Hardy, representing the Nevada Conservation League. When my wife and I were in college, we both worked at a funeral home, and we would see these families come in, and they were mourning for their deceased loved ones, and they would spend thousands and thousands of dollars on these packages to honor their loved ones. This method offers a more affordable option to be able to. It's more affordable than traditional burial, cremation, and it's a more personal and meaningful way to dispose of a loved one's remains. We are in full support of this bill, and we urge the committee's support as well. Thank you.
Thank you so much. Anyone else in Carson City? Moving on to virtually.
If you would like to testify in support of AB 289, please press star 9 or raise hand within Zoom to take your place in the queue.
For the record, my name is Chris Bell, that's CHRISBELL. Chair Donyate, members of the committee, I'm a volunteer member of Sierra Club's legislative.
I'm sorry. Can
On
you
behalf
can you
of the
speak
club, the
closer to the microphone, please, and repeat your name for the record?
Yes, sure thing. I'm sorry. For the record, my name is Chris Bell, that's CHRISBELL. Chair Donyate and members of the committee, I'm a volunteer member of Sierra Club's Legislative Committee. On behalf of the club, the world's largest environmental volunteer organisation, and our more than 30,000 members and supporters statewide, I'm speaking in support of AB 289. America is great thanks to choices available to citizens, from voting to purchasing goods and services. This bill adds a very important, long overdue choice for how we choose to be dealt with after death. The Sierra Club sees the option for natural organic reduction as an excellent way for the industry to reduce fossil fuel consumption while providing another choice for people and their families. It will also relax pressures on very long-term land allocations and formaldehyde contamination that ground burial poses. With government, business and consumers now painfully aware of the threats posed by climate change, all sectors need to provide low-carbon alternatives. It has been reported that cremation in our country accounts for 1.74 billion pounds of CO2 every year. 6 states have already passed legislation supporting human composting. Please support this legislation to allow Nevadans to choose this environmental options. For these reasons, we urge you to support AB 289, and thank you very much.
Good almost evening. I'm Chair Donyate and members of the committee. My name is Matthew Wilkie, MATTHEWILKIE for the record, and I'm calling in full support of Assembly Bill 289. This eco-friendly alternative to traditional cremation methods allows individuals to leave a positive impact on the environment even in death. The inclusion of natural organic reduction to the definition of cremation is a welcome update to existing provisions. I also appreciate the exemption for soil resulting from natural reduction from certain requirements, which makes this process even more appealing to those who value sustainability. Thank you for considering this bill and supporting environmentally responsible options for a disposition of human remains. Thank you so much for your time. Have a great evening.
Chair, there are no additional callers at this time.
Thank you so much. Let's move on to opposition. If you are in opposition to this bill, please come forward. There's no one here or in Las Vegas. BPS, anyone virtually?
If you would like to testify in opposition to AB 289, please press star 9 or raise hand within Zoom to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. And anyone willing to testify in neutral on this bill, please come forward. Seeing none here or in Las Vegas, BPS, anyone virtually?
If you would like to testify in neutral for AB 289, please press star 9 or raise hand within Zoom to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Assemblyman McCarty, did you have any closing remarks? I do have one question, if you can come forward, please. What's his tree? Oh, that's a good question. So, first question is, what would be your tree? You have to answer that too before we close the hearing.
Max Carter. Mine would be a mesquite. I'm a native-born Nevadan, and there's nothing more Nevadan than a mesquite tree.
That's a good one. I would be a willow tree, but it depends on the day. Now, the more serious question, I've been thinking of the plots of land that this would be distributed in. If you have a lot of trees, right, in a nearby area, some may argue that this could become a haunted forest. So can you please elaborate if this bill would lead to a haunted forest?
Anything's possible, and who knows, Max Carter, who knows? Nevada's very good at turning anything into a tourist attraction, so we're going to leave that one open.
That was a good response. I think we'll go ahead and close this hearing, and we appreciate you for joining us here today. We're going to move on to Assembly Bill 11. This bill revises provisions relating to, give me one second, governing hospitals. With us, we have Senator Maggie Carlton, and so please begin when you're ready for the bill presentation.
Thank you very much, Mr. Chairman. Appreciate being on the second floor. And if I could take just a slight moment, I'd like to congratulate my friend, Dr. Titus, for being on the second floor. It's very nice to see you here. So with that, Mr. Chairman, I am Maggie Carlton, formerly Senator of District 2 and Assemblyman of District 14. I am here in my capacity today as the person who worked on a lot of the Patient Protection Commission items through the legislature. So just to give a little bit of perspective, over the years in the legislature, when we've tackled very large healthcare issues like your committee has tackled this session, I'm sure, we've worked on a number of different things, and working through the process of, especially with surprise billing, we started to have these conversations about how do we really address these big issues when you're limited in 120 days. And we have interim committees that do a lot of work also, but they can only do so much in an interim. So to be able to really put together data-driven policies, the idea was that we would create a Patient Protection Commission. So after we passed surprise billing back in 2017, we started to work on establishing the commission. Former Governor Sisolak had mentioned the commission in his budget, and I worked very closely with him. We had started working on the proposal. So we got it started in 2019, and it was doing a lot of really good work about just addressing all the individual items. Then in 2021, we made some changes to it, because when you do something the first time, sometimes it's not quite right. So you make adjustments. The commission, I think, has done an excellent job in tackling very complex healthcare issues. One of the reasons why I am here today is because the former executive director of the commission is no longer there, and there was no one to actually present the bills because of the protocols of the legislature. A person that's working in the commission as a commissioner or in support of the bill really can't be the person that opens it up and presents it. So as the legislator that tackled these issues over my 20-some years, I was asked if I would come to Carson City and present these issues to you. So with that, today, one of the three bills that came out of the Patient Protection Commission, and it was by consensus, when they vote on their bills and they narrow down their subjects, they do it by consensus. So it is a give and take atmosphere that these bills come out of the commission. There was a request by the current administration that the work of they do not advance this legislation, ask the commission not to move it forward. I was concerned about that. I think it's important that the commission spent all the time and effort to work on these issues, that these pieces of legislation that had already been drafted, were in the queue and ready to be discussed and debated, should still be presented to the legislature. There was no reason to not have the discussion. It's up to you to decide what the public policy is in this state, not for someone to say, don't work on something, I don't want it to go forward. So with that, I was asked to come and just give you a little bit of history on this, and more than happy to answer any questions.
Good afternoon, Senator Duniati and Chairman Duniati and members of the committee. Thank you for hearing this bill today. For the record, my name is Babette Bond. I haven't been before this committee at this session, so for those of you who I've not met before, it's a pleasure. And I am here in my capacity as Vice Chair of the Culinary Health Funds Policy Program. So I am a commissioner, and so to what you just heard from Senator Carlton, the commission is not usually in the role of having the commissioners speak about the commission bills, but this has been a unique session, and because the PPC bills didn't have someone to present them. And this is the first of 3 bills, as Senator Carlton just said. And I don't know if the other two will make it out. If they do, they'll be here in front of you as well. So I want to just spend some time talking about the history of how we got here with the Corporate Practice of Medicine bill. And then, if you don't mind, it would also be great to introduce a co-commissioner who's in Las Vegas, just so you know he's here, because we're trying to do this in tandem, and we were in person in the last hearing. So is that appropriate, Chair? Okay. Can you hear?
I can. Good afternoon. For the record, I'm Mason Van Howling. As Ms. Bond mentioned and Ms. Carlton, I would be shoulder to shoulder with my colleagues there, and I appreciate the description of all the hard work from the Patient Protection Commission. For many years, we've had very thoughtful processes, very deliberate conversations for hours on end, and again, we're very proud of these bills that we've been able to move forward. So I'll follow after Ms. Bond, but I apologize. I typically would be there in person, but it's been a very busy day at UMC and Hospital Week, Nurses Week, and lots of other things going on at a neighboring hospital that didn't happen today, but we're anticipating and being ready. So thank you, Mr. Chair.
Thank you. Again, for the record, Babette Bond. So, as you've heard maybe a couple times, there were, I think, 15 different bills were presented to work through over the life of the last biennium for the commission. And out of those 15 bills, there was a series of bringing the information you had. You know, what are the proponents of the bill saying? Are there issues that make this a concern for the PPC? And whittling it down over the course of, I think, 6 months to the 3 that were actually created. AB 11 is about Patient Protection Commission, concern about corporate practice of medicine. The other 2 are about trying to make sure patient access to medical records is easier and interoperable. And the 3rd one is about trying to create a benchmark program in the state of Nevada that would start to work on tracking the cost and the price of healthcare as we try to control healthcare costs. But here's corporate practice of medicine. So I'm going to go through the history of this law in Nevada and the reasons it ended up becoming a concern for the Patient Protection Commission from a patient's perspective. What's happening now, happening right now in, let's see if I know how to make this work. Oh, did I get it? Okay. So what's happening right now, we'll back into it, is there are physicians being hired as employees in private hospitals in Nevada, and it wasn't always so. There are laws on the books that created structure for something called corporate practice of medicine, which means that can a corporation hire physicians or can a corporation not? And there's 3 AG opinions that have come out since 1970 trying to address it, and it's because Nevada has a strange approach to the corporate practice of medicine in statute. Instead of listing who can employ a physician, Nevada history is to list, the opposite. Instead of listing who cannot, sorry about that, I'm making it more confusing, who cannot operate as an entity that hires physicians, the state of Nevada and many other states list who can. So those that can are listed in statute as the exceptions, and everybody else cannot, and that's the way it's been in Nevada until relatively recently. So I'm going to go through the 3 AG opinions and sort of the other small evidence we have from testimony suggesting what has been the state of play here up till now, and then talk about why we want to move forward with this bill. So the first opinion about whether physicians could be hired by private hospitals came in 1977 when Robert List was the Attorney General. And these documents are in your portal, and I see many of them are also printed, but I just wanted to highlight and make it easier because I know there's no way you can go through 80 pages of documents, the key pieces of what we're talking about. So physicians and surgeons under corporate practice of medicine legal could only be done through Chapter 89 of the Nevada Revised Statutes, and it was illegal to hire a doctor if it was done under Chapter 78 as a corporation. The conclusion of this first question to the AG was that the corporate practice of medicine by a general corporation organized under 78 of Nevada Revised Statutes is not legal. Nevada licensed physicians who aid or abet in a corporation to legally practice medicine may be charged with unprofessional conduct and have their licenses suspended or revoked. Just to clear up things a little bit today, we're not trying to talk about all corporations. This bill is specifically targeting hospitals hiring physicians because the concern that came to the Patient Protection Commission was the problem with not being able to access a physician in a hospital in the absence of prohibition. So here's 1977. Next one is in 2002, this came up again, and Frankie Sudapapa was the AG, and she was asked to opine on a couple of questions related to corporate practice of medicine. But her findings was a review of Nevada statutes and case law reflects that the law is generally unchanged from the previous opinion, which was the one from Attorney General List in 1977. The corporate practice of medicine is still prohibited unless in the form authorized by NRS Chapter 89, 695, B, C, F, and G. And if a corporation is engaged in the practice of medicine and does not come up within one of the above referenced statute, it would be unlawful. So that was 2002. So still unlawful. Then in 2010, the AG, who was at that time Catherine Cortez Masto, was asked again. And she had a longer document, which again is in your portal if you have the time to read it or a reason to read it. And she opined that, as I stated earlier, the state Supreme Court and the Nevada Legislature have never expressly determined that private hospitals licensed under NRS 449 cannot employ a physician. Yet, it's been a longstanding practice in Nevada. Physicians only work as contractors for private hospitals and not as employees. To depart from this practice would mark a significant change that would be tantamount to a change in state public policy. And that leads us to your doorstep. You, the Nevada Legislature, is the reason that we're here today. In addition to, so it was left at that in 2010. Nothing has been legislated since then, since her request that this be legislated, and nothing has changed in the history of NRS. There is a little more history that we can see that's just kind of lends credence to the notion that this was considered something that could not happen. Private hospitals could not hire physicians. Private hospitals could contract with physicians, and private hospitals could provide privileges to physicians, but private hospitals could not actually hire physicians. There was a legislative commission in 2002, long ago now. I'm not sure any of you were here then, but I was here in this hearing. And even this commission was to figure out the relationship that quick cares and hospitals should have in the private sector and the nonprofit sector. And under item 6, Alan Stipe, who was actually the chief executive officer and president at that time of Sunrise Hospital, he was testifying about the impact of the hospitals and the quick cares. And he referred, and what you can see in yellow, he referred to Nevada's corporate practice of medicine law as an unnamed federal and an unnamed federal statute, which we can opine about that, said that private sector hospitals cannot hire physicians. UMC, however, can hire physicians. He additionally explained that private sector must demonstrate medical malpractice, but that's not why we're here in this hearing today. There's another hearing about that. But even the president and chief executive officer of Sunrise Hospital believed, and nothing's changed since, that private hospitals do not hire physicians. They contract with them. Then in 2007, there was a hearing with Senate Bill 412, and here's some of the testimony from that. There was an attempt in that bill, which actually succeeded in increasing the kinds of facilities that could hire physicians. But in this testimony about Touro University, the state of Nevada, there is a prohibition against corporate practice of medicine of corporations not owned by physicians. The AG has written legal opinions on 2 occasions, and the result is that private non-for-profit corporations such as Touro University, let me go to the next page because it's got cut off, cannot hire them. So they actually came to the legislature, which is what in 2010, later, Senator now, Cortez Masto was at that time AG, promoting, bring it to the legislature and figure it out. That's what they did. They brought it to the legislature to figure it out. And so Senate Bill 412 was actually legislating that, okay, in addition to what's already in statute of who can hire a physician, this nonprofit medical school and a nonprofit medical research institution were added to NRS to allow those groups to also be able to hire physicians rather than contract with them. So we have those 3 AG opinions, and then we have these testimony from related bills that kind of set the record on, you know, what our position as the Health Services Coalition, which has done 20 years of hospital contracting, has always thought was the situation as well. And as we've heard from the Nevada Hospital Association up until this year, that physicians are not hired by private hospitals. They're contracted with them. They provide privileges there. The American Medical Association has issued some opinions about this in 2015. Their doctrine in 2015 arises from the reasons that you would not have physicians directly hired by the hospital. They more succinctly than I, say that the problem with physician employment rather than contractual relationships is medical care becomes even more commercialized. Obligations to shareholders may not align with physicians' obligations to patients, and they can interfere with independent medical judgment. But we have 2 additional problems occurring in Las Vegas besides the ones that the AMA is pointing out here. One is that we are a state, as you will hear from everybody who comes to the table, and you probably heard all session, with some pretty serious physician shortages. So causing more shortages by having doctors tied up with one facility that they work for instead of ability to be able to provide privileges and services at all of our community service hospitals. And I do think of our hospitals as community servants in a lot of ways. They're community assets. Patients need to be able to get to them. And so in that way, they're not like an Amazon or another kind of facility. They are a unique entity in the state of Nevada, and I think that's something we'd probably all agree on. So this problem is occurring, the reason it's come to the Patient Protection Commission is that we do have these shortages, so we don't have enough hospitals, we don't have enough doctors to go around and be hired by every hospital. But we also have a real movement in Nevada and the whole country as well towards consolidation of the hospital and healthcare industry so that it's easier for hospitals and healthcare systems to build market share. And as they do that, as they consolidate, they want the physicians on their staff, because if they have the facilities but they don't have the doctors, they can't provide services. So the doctors are a key reason that the hospitals are in business at all and need to hire them. But it has set this other problem in motion. I think this is a good time to go to, if it's okay with you, Chair Doñate, to try to go to Mason Van Howling and have him talk about his perspective on this before we go on.
Thank you so much, Mr. Van Hollen. Please proceed.
Thank you, Mr. Chair. Again, Mason Van Howling, Chief Executive Officer of University Medical Center, but also a Commissioner on the Patient Protection Commission. So as Ms. Bond alluded to, and I'll kind of pick up from there, as you all probably know, UMC is the largest public hospital in the entire state. We've been serving our community since 1931 with 1 doctor and 1 nurse taking care of the workers at the Boulder Dam. Fast forward to today and really the highest level of care in the state, but very proud of our large teaching mission that we train in the next generation of healthcare workers. We've had about 2,000 students that come through our doors every year. As mentioned, I'm one commissioner on a panel of 12, and we've got 4 non-voting members. But just to also talk a little bit about the corporate practice of medicine that applies to hospital corporations. It is an existing law meant to protect the sanctity of the physician and patient relationship. So decisions are made in the best interests of patients and unfortunately not in the corporate bottom line. The corporate practice of medicine doctrine requires clarity in Nevada, as Ms. Bond alluded to. As you can see, we do need to clean this up and bring clarity. There are clear exceptions currently found in Nevada revised statutes. And NRS 450.180 is one, and then also NRS 630.365. Both the actual prohibition is discussed in 3 Attorney General opinions, as Ms. Bond laid out. And again, it's just really time to bring clear rules to around the law and the policy that already exists. Except in limited situations set forth in clear NRS exceptions that I just mentioned, physicians form their practices utilizing professional corporations and professional limited liability companies. One reason for this is to ensure that the individual malpractice liability will pass down to the physician owners. Most, if not all, healthcare professional licensing statutes already contain what's called fee splitting, a technical and a professional component. Therefore, even states that do not follow a corporate practice of medicine, these professionals need to be extremely concerned when they're sharing their fees for their professional charges without a clear exception under law. So really today, on the behalf of the Commission and Ms. Carlton and many, many of our Nevadans, your support and advocacy of AB 11 today will continue to protect patients in the state, will not allow for the commercialization of medicine. As Ms. Bond, you're going to hear a lot of things today, and we know that we already have a shortage, but this will also prevent a misalignment of physician obligations under the Medical Practice Act, impact overall care, and again, not exacerbate the shortages that we are all well aware of. It also ensure and grow independent doctors working at multiple hospitals, as Ms. Bond says. You have the ability to contract and be privileged through any hospital. And then lastly, keep our patients being directed to specific hospitals, thus reducing overall consumer choice. So with that, Mr. Chair, I'll turn it back to you for any questions.
Thank you so much. Does that conclude the presentation so we can go to questions?
No, it does not.
Please proceed, Ms. Bond.
Patient, thank you. And I didn't get to decide which tree I wanted to be either, which is, concerning. All right. Chase tree. I'd be a chase tree. That's my favorite in my backyard. All right. So what are other states doing on this? We did a scan on this last year, and 17 states have no corporate practice of medicine doctrine at all, but 2/3 of the states in the country do. 34 of them have something that they do. The 17 states, there's a longer document again in your portal, but 17 states have none. 12 states create an exception for nonprofits. 11 states create an exception for specific types of nonprofits, and then 11 states have no nonprofit exceptions at all. We have, as you just heard from CEO Van Houweling, that we have a mix in this state. There are specific places in NRS where it is allowed, and the exceptions prove the rule that the rest are not allowed. So that's what other states are doing. So key points from where we are right now, just how far we've gotten today. We've cooperated under this corporate practice of medicine for at least 45 years. We have these 3 separate AG opinions that support that. Physicians have not, until relatively recently, and not all over the state, begun to be hired by hospitals. I think it depends on the region of the state that you're in, what's happening. And since that time, since 2010, there have been some attempts in the legislature, I've been here for them, to try to have, the Hospital Association has come and tried to legislate that they can hire physicians, and that legislation has never passed in this state. So we're at the same place we were when this opinion was issued in 2010. The statute does offer these exceptions, and I think that it's important that we acknowledge those, and AB 11 intends to sort of expand that a little bit, and I'll talk about that in a second. These 2 slides, I don't want to dwell on them because we're here for other business today, but these hospitals are doing really well in Nevada, and I want to say that just preemptorily because I've heard in testimony in other hearings and in this hearing in the other house that they're, still struggling to get on their feet from COVID. And I just would like this committee to be well educated on the fact that there's $1.8 billion in net income in the last 4 years that's come into these hospitals. But more importantly, there's 4 systems that own 70% of the revenue in the state. So HCA, UHS, Renown, and Common Spirit between them have 70% of the revenues in the state. And there's 14 rural hospitals and 1 county hospital that make up the rest. So those have 30%, but these 4 systems have 70%. And the reason we feel strongly about it from a coalition perspective, and the reason many of the PPC members have felt strongly about this, is this consolidation is just increasing. It's getting bigger. And most big systems in Nevada hospitals have healthy profit margins. So AB 11, what we wanted to do, this is what we did in the assembly. This is what the PPC agreed to. Confirm the long-standing practice that the opinions of the AGs is where we are with the law, not to hire physicians in private practice, keeping the exceptions that are in state statute, but add an allowance for GME programs in hospitals to also be able to hire doctors. We've spent quite a bit of time on GMEs in past sessions. I don't know how much time we spent on it this session, but I think there is a lot of agreement amongst all of us that more GME programs in the state of Nevada is something that we should carefully consider, and something I think the PPC wanted to get to and hasn't yet. We also want to ensure patients can get care at all hospitals with doctors that have contracts or privileges, as is the current state law. We want our doctors in Nevada to be able to get to any hospital that they have privileges at, that they want privileges at, and we want them to be able to be contracted to do that. But we just have a concern that there's going to be a lot of patients in hospitals with no doctors if we allow the current lack of containment to continue, because we just don't have enough doctors for every hospital to hire their own. We just don't. So that's what the law was intended to do when we brought AB 11 in from the PPC into the Assembly. In the Assembly, it was then revised. It was amended, and there's a couple of important provisions that were added to it that I don't have a slide about. But those are in the testimony and in discussions. A lot of concern was raised about the practice now of hiring physicians includes significant use of non-disclosure agreements and non-compete clauses. And that was a concern raised by doctors, that was a concern raised by other legislators, and that was a concern that we've heard privately. So the bill was amended and supported in that committee to make sure that this bill includes that can't happen anymore, that hospitals can't require those non-compete and non-disclosure agreements for doctors. And one of the reasons is it was adding to shortages, because if a doctor had signed a non-compete clause and then stopped working, he would be unable in many cases to find another job in that community during that 2 years of non-compete. So that was one change. The second change, importantly, is creating an interim between now and the next session, a committee that can actually take a longer look at what should we really be doing about these physicians. Where, if anywhere, is it appropriate for these physicians to be hired by the hospitals that we don't already have? Take a longer look at, what are the net impacts of corporate practice and medicine law and the lack thereof, and try to figure out how we can work together on getting as many doctors in the state as possible, but also making sure patients in every hospital have a doctor they can see. And I know we have different visions of how that should go, but that is the PPC's perspective to this point. I'm glad it's going to happen in interim health if this bill passes. I don't know if it's interim health, actually. Is it? Okay, just make sure. Because I'm not sure with the Patient Protection Commission, there's 12 members in the commission. There's at least 4 of us have our term expiring in June. So our terms are expiring, and there'll be a transition. I don't know what's going to happen to the PPC, but I'm glad. I would hope that this would be. The interim health seems like a really good place for this work to continue, and I hope that you can support this bill as we try to move forward with this issue. I don't know. Co-Commissioner, did you have anything you wanted to add? I'm sorry, Chair. I just wanted to make sure I'm not leaving him out.
Mr. Van Hollen, did you have any other comments?
No, sir. Mason Van Halen for the record. No, Ms. Bond, and no, Mr. Chair. Thank you.
Thank you so much. We're going to go ahead and proceed to questions. So thank you so much for that presentation. We'll begin with Vice Chair Nguyen.
Thank you. It's good to see you back in the building, Senator Carlton. I have a couple of questions. I know that coming from the practice of law, it's too bad there isn't a similar kind of structure, like you can't have fee sharing and you can't be partners with non-lawyers. And when we see this corporate practice of medicine, it obviously is concerning to a lot of people, including myself, that we have venture capitalist firms and other people that are working on profit and not necessarily health, making decisions about profits over people potentially. So I appreciate the intent of this bill, and I was wondering if there was any consideration, I know this goes beyond this bill, but expanding some of this non-compete language to other areas where you see the corporate practice of medicine where they are certain, I don't know if there's a desire to expand this outside of the hospital field as well. I know that you've worked a lot to talk about some of that transparency with provider groups, not being able to leave a certain provider group and they have to go there. And so I was wondering if there was any intention to want to expand this to protect patients in other aspects other than hospitals.
Chair Dunyate, through you. Senator Nguyen, I think that actually was a question that came up in the PPC, but then the PPC had to finish its business. And I think certainly from my perspective, it would be good to have our doctors have as much freedom as possible to operate where they want to and need to. And I don't know what the complications of that would be, because we certainly need to still follow HIPAA laws, and and we would. So we would embrace that. But I'm speaking as a coalition member who does hospital contracting, and not as a PPC member when I say that, because PPC hasn't blessed that.
Thank you so much. Vice Chair Nguyen, did you have other questions?
I do, if that's okay, Chair. I guess my other question is I had the opportunity to listen to some of the hearing and some of the opposition about how some of these hospitals have the only ENT in town. Obviously, I have concerns that if they're in one place, that they can control, I guess, the pricing and costs because they're the only game in town for that particular specialist. Do you think that prohibiting this in law, and I agree with you, I think it probably shouldn't be doing it anyway, but to specifically put this in law that this is not allowed would increase, I don't know, I'm kind of thinking out loud here as I'm talking, but when we already have a shortage of those, any particular specialty, can you kind of explain how that works from a patient perspective, I guess, for if there's only one specialist and they're working at one hospital, what that means for, I guess, patient choice and patient pricing?
Senator Giannotti, through you. For the record, Bobette Bond, I would like my co-commissioner, Mr. Van Helling, to weigh in on this as well. But let me just tell you, because you're asking from the patient perspective, and I know he has strong opinions about patient perspective as well. But I would say what we're seeing, and the reason there's so much movement now, is the industry is heavily consolidating. Hospitals are buying physician groups, and they're buying surgery groups, and they're doing that in the name of efficiency, but it also generates monopolies. And so if you have a one ENT, to your example, and they only operate in one hospital, then whether that patient would choose that hospital or not, they have to go to that hospital now for that ENT, because that ENT, if they're on staff, hired, an employee, not contracted, they don't have the opportunity to go take care of that patient in another hospital. And that is exactly the problem that arose that the PPC heard about. But are you okay? I don't know how to.
Mr. Van Helling, please proceed.
Without.
If you can respond to.
Yes, sir. Mason Van Halen for the record. Chair, and Senator Nguyen, if you don't mind, certainly I do, your last question in regards to non-compete, I get an opportunity to spend a lot of time with doctors that unfortunately don't have great legal representation that you were talking about earlier, and don't realize once they sign some of these hospital contracts that there are very strict non-competes within radius, within certain areas of the community or with even in the state. So obviously, once they go there, they ultimately have to leave the state or leave the community and can't even do some things as such as telemedicine or teaching and academics. But to answer your question specifically in regards to what that looks like, I can give a very specific example of a crisis that we had. Fortunately, we averted within days, but cardiovascular thoracic surgery. You have your primary care doctor that refers you to a cardiologist, and they notice something that maybe you need a valve replacement, or you have a major heart attack or some type of trauma that requires the surgeon to intervene. And unfortunately, in Las Vegas, we just don't have a lot of those right now. And unfortunately, the doctors that we did have were recently employed with very strict privileges, can only be at one hospital, but also not very strict non-competes. So, which left really the community that if you didn't go to that particular hospital or you didn't live on that particular side of town, you were looking potentially of leaving the state to have your procedures. And UMC being the only level 1 trauma center, cardiovascular thoracic surgery is part of our requirements. And imagine not being able to have a cardiac surgery that's much needed, and you would be kind of left without any options. And so we avoided that crisis, but having the corporate practice of medicine would not take up the limited resources. Again, you're going to hear after we talk that we're in a doctor shortage, but there really was no solution on backfilling those doctors and really put patients in peril. So with that, I'll turn it back to you. Hopefully that answers your question, Senator.
No, it does. Thank you so much.
Thank you so much, Senator Titus.
Thank you, Mr. Chair, and Senator Carlton. It's good to see you also. And indeed, we did have our moments in the Assembly together that where we agreed on, but I think our most contentious moment where we didn't agree was some issues with the Patient Protection Commission. So having said that, good to see you. I have a lot of questions. First, I have a question for Mason Van Halen? Is that correct? Van Halen. Sir, does UMC...
I wish I had that last name, Senator, but
does
I apologize. I was making a good joke. But
does UMC hire physicians?
Mr. Chair, through you, if I could answer the Senator's question.
Directly, please.
Mason Van Halen for the record. Yes, ma'am. We do have employed physicians. We, as mentioned, we are exempt from the corporate practice of medicine.
Yeah,
And that
so
was really,
I'm going to stop you right there. So you're exempt. You're exempt from the. So the answer was yes. You employ physicians. So you're exempt
Correct.
from a bill that you're testifying that we should support. That's my first concern. Second, do you allow your hired physicians to work at other hospitals? Because one of the issues with this is that we're concerned doctors can't work anywhere else.
Sure. Mason Van Halen for the record, Mr. Chair, through you. Senator, so you asked two questions. The first being, do we employ physicians? Yes. And then we are exempt, as mentioned, and why we need clarity to this. The reason why we do hire physicians and have for decades and decades is because UMC provides services like no other. Obviously, our charitable mission that we've always had, but also our academic and teaching mission, as Ms. Bond said, that GME and academic and teaching are exempt for that. So UNLV is exempt from that as well. So just not UMC, but also UNLV, but also the other public hospitals throughout the state. So I know UMC is the largest, but this also helps other hospitals throughout the state that provide that mission. And did I answer your second question?
No, you did not, because I think I'm concerned there's a conflict here. And so do you let your doctors work at other hospitals?
So Mr. Mason Van Halen, for the record, Mr. Chair, through you to answer the Senator question. So we our doctors will work like any other employee 40 hours a week. We require them to work during those hours that they're covered and staffed. They are privileged and credentialed at UMC, but we don't limit them to work at other hospital after hours. They want to do event medicine or telemedicine, but while they're employed at UMC, obviously, as you can imagine, they're an employee of UMC. So they're not running around the community. They're often teaching and doing our safety net mission.
So if they're, just for clarification, so when they're working, obviously they're in your facilities, they're doing telemedicine, but when they're actually in your facility, you allow them to go work at another hospital, work at another clinic, see patients off-site, not associated with UMC?
So Mason Van Houweling, for the record, Mr. Chair, through you to answer the senator's question. So again, if they're working at UMC and on the clock at UMC, they're practicing at UMC at our hospital or one of our 14 clinics or doing our telemedicine. Again, after hours, many people have part-time jobs. Nurses have part-time jobs. I've had a part-time job serving our country for 25 years in the Air Force. So again, they're not running around covering other hospitals. Other hospitals have the ability to contract. And again, I think we need to underscore that they can contract with any provider in the community, any ENT or urology and those type of services. But obviously, and mainly because of the medical malpractice insurance senator, that doesn't travel with them at other hospitals. Physicians typically buy their own med mal, and obviously we buy that on the behalf of the employee of UMC as a physician, but that doesn't carry on to other facilities.
Right, so thank you for that. Just so you know, I was in private practice for a number of years, but could not afford to stay in private practice, so went to work for a rural hospital district. It's the only way I could have survived in the practice of medicine. So it's not all some big corporation to survive. So just to be clear, UMC hires physicians, but you're testifying on a bill that won't let other private physicians, private hospitals hire physicians. You do allow your doctors to work at other facilities, but they have to provide their insurance. Is that what I'm hearing you say?
Mason Van Houweling, Senator, Chairman, through you to answer this. I do want to leave very clear so you're not leaving with unclear answers, Senator, and we can break these down. So again, if you're an employee of UMC, you're obviously obligated to work at UMC. What people do after hours or do on the weekends, obviously, that doesn't go under the UMC flag, much like a nurse and employed at UMC, a respiratory technician. So again, they're obviously scheduled and committed via an employment agreement with UMC. But so again, I don't want you to think that they can just jump up to another private hospital during their shift. Obviously, we're covering that because they're covering the trauma center, they're covering a NICU, they're covering a transplant case. So obviously, again, UMC is exempt for that, and probably that hospital you worked for was part of that NRS exemption to the corporate practice of medicine.
And so thank you for that. Going to Ms. Bond here, I know you're on the Patient Commission, Patient Protection Commission, but you have another employment. You work for the Culinary Union, do you not?
Senator Titus, I would ask that we keep this comment, these questionings directly to the provisions of AB 11.
It's absolutely relevant to that. And it's about, so do you not do that? Do insurance companies make profits?
Once again, Senator Titus, I would ask that we please keep the comments to Assembly Bill 11.
So let me circle back to this, because one of the issues with this assembly, your concerns about hiring physicians and the corporate practice of medicine, is the fact that, heaven forbid, medical providers make money. And it's an issue that I have with this corporate practice. You want to control us so that, heaven forbid, we actually survive in this world of overregulation. And now somehow, if a private company wants to hire a doctor, you're worried that we might make a profit? Is that correct?
Mr. Chairman, if I may, thank you.
Please proceed.
Thank you very much. Maggie Carlton for the record. So in some of my investigations, as I was working on corporate practice of medicine, and then the PPC was working on the corporate practice of medicine. I asked some questions, as any legislator could, to get some research on it. And I had gone through a number of different documents that were provided to me. And the American Medical Association came back with a couple of bullet points that I found very, very important. That a corporation's obligations to its shareholders may not align with a physician's obligation. So this isn't just about the patient, this is about the physician and the corporation. The physician should have the autonomy to treat the patient the way they would like. And I think Dr. Titus and I would agree on that. A corporation should never oversee what that physician does. So I think that's a very important point to make. I don't think this is about the money. I think this is about access and making sure that physicians and corporations all stay in their career. When you employ the physician, that may interfere with the independent judgment of that doctor. If that doctor says that this physician needs a certain treatment and that hospital wants to say, well, we don't do that, you can't do that here, and they've hired that physician, what is that physician going to do to get the treatment for that patient? And being a mom who's had to take her kid out of state to get care because we didn't have a doctor in this state to treat her, that's bad enough. For years, we talked about the best place to go to get medical care in Las Vegas was to the airport. We don't have to do that anymore. We've brought physicians into the state. We don't have enough. We need more specialists, and we're going to keep working on it. We have a medical school. We're going to get there. I feel we're going to get there. But how would you feel if you were a mom and had to take your kid out of state and you knew there was a doctor at a hospital 3 miles away that could have treated them but wasn't allowed to because you don't have access to that hospital? So this is really, it's not about the profits, Dr. Titus. This really is about the patients having access to a physician that has independent thought and action and is not controlled by a corporation. That's really where the essence of the corporate practice of medicine lies for someone who's just a regular patient like me. That's how I see it.
Thank you, Senator Carlton.
Just a final
Senator-
comment on that,
Yep.
because it is
Yep.
relevant to the bill, and thank you, Senator Carlton, I appreciate that. Just from my perspective, obviously, I have a strong opinion about this bill, and you hadn't noticed. Having said that, however, just for clarification, as a provider and a physician who was employed, at no time was my medical judgment based on the fact that I was employed by the hospital, but instead what we could offer in that location that we were at. And so, I'd be interested to see where, because none of your testimony did I see or hear any real justification other than the concern that perhaps the doctors, number one, wouldn't be able to order the tests they want to do. So I haven't seen justification that there was an increase in charge or somehow these horrible private hospitals had now tied up these doctors. I do agree with a component of the bill, however, the non-compete clause, because I think it's critical to supply providers. But I don't see in here when you talk about the whole change in how we practice medicine. Most docs don't go into the hospital and see their patients any longer. You have physicians that make those rounds. You have hospitalists. And so the whole change of medicine, how you practice medicine has changed. And to regulate that into a narrow scope is, I think, wrong. And the other observation I want to make, and relevant to the bill because it was in your testimony, from when you started with Attorney General List and you ended up with, then you talked about Frankie Sue Del Papa, and then you mentioned the final our current senator, their statements, none of them say there's anything against it to do it. But now you want to codify that there is in statute where we can't hire physicians. So I would just submit that as a physician from the other side, I understand what you're trying to do, but I think your bill does just the opposite of what you're trying to do.
Thank you, Senator Titus. Senator Stone.
Thank you, Mr. Chairman. And Senator Carlton, it's nice to meet you. I don't think we had an opportunity to meet, and appreciate the presentation. It was in your testimony that we heard that the profit word. It wasn't something that Dr. Titus or I brought up. It was these corporations are making a lot of money, and it just seems like in my short tenure here in Nevada that profit seems to be a bad word, which I don't think it is because I'm a true capitalist. Pharmacist by profession, owned a bunch of pharmacies, which I sold my last one back in January. But I'd like to kind of share with you a little bit of my experience. I was a county supervisor in Riverside County. We had a county hospital. We hired physicians. We hired top-notch physicians that gave top-notch care to people that didn't have the resources to get into some of the private hospitals. And of course, they taught as well. Also, the practice of pharmacy has certainly transitioned. I graduated pharmacy school, wanted to have a chain of very small apothecary pharmacies where you knew everybody's name, like a Cheers bar, you know. And I can say that I kind of lived that dream. And then we saw the rise of the chain stores. I ended up getting bought out by a couple of chain stores and a couple of stores, and pivoted and went into compounding so I could still continue to be the master of my destiny and the master of my patient's destiny. And I was well rewarded for it. We have a shortage of specialists. We have a shortage of primary care doctors. Agree 100%. I wish in Nevada, like in California where I came from, that every bill got a hearing, because we actually had a bill that would have done occupational licensing recognition that would have allowed some of these specialists to come into Nevada without the bureaucracy and time in getting here and having to take exams. So we do have a limited amount of these professionals. And, you know, I think after the COVID crisis, I think we burned out a lot of our healthcare professionals, our nurses, our primary care doctors, our specialists, and rising insurance with inflation, personnel issues, and many physicians just want to just go work for somebody. And you have these specialists, you talked about, I think, thoracic surgeons get hired by a hospital. If they want to sign a non-compete clause with that hospital, I'm sure they're getting paid for that non-compete clause. I'm sure they're not just signing it away. Whether they work at one hospital or multiple hospitals, because you only have one of these specialists in a particular area, they could probably spend more than full time in just one of the facilities. So if you want to call it a monopoly, the monopoly is still there because there's still one provider that can provide that service and not another, to the benefit of the hospital that certainly hired them. But I think we're seeing the construction, if you will, the foundation of medical care. I think it's transitioning, unfortunately, just like we've seen the transition of other industries, the retail industry. Look at the impact that Amazon has had on bricks and mortar facilities, even getting in the pharmacy business, you know. But this is what they call progress. Things that can be done more efficiently, can be done less expensive, can become more competitive. Those are going to prevail in a capitalistic society. I don't want to certainly strap, you know, what a hospital can do, with who they can hire.
Senator Stone, is there a question in
I'm getting to it.
Okay.
I'm getting
Thank
to
you.
it, sir. Now I just lost my train of thought. See what happens when you get to be 67 years old? I kind of believe in a freedom of choice, you know, for the individual, for the hospital, for the entity, for the medical group. If somebody wants to go into private care, they can go into private care. But I'm trying to understand how, when I think the issue is bringing more specialists into town so that there is competition, I'm trying to understand when we've had two attorney general opinions that you say have alluded to the fact that corporations, namely hospitals, can't hire physicians. But I think that Senator Cortez Mastos' opinion, and I read it, I think it makes it very clear. It may not be the practice of previous administrations, but I think she makes it very clear that it is lawful. And I would opine that the purpose of this bill is to codify in statute that it gets rid of this gray area. So is that how you see this bill, to kind of clear the air on the ambiguities as to whether or not a hospital can hire a physician, or osteopathic physician or allopathic physician?
Before we answer that, I would like our legal counsel to clarify what the statements of the opinion are from Senator Cortez Masto and what they have alluded to before. I think that's important as part of the record.
Eric Robbins, LCB Legal, for the record. My reading of the legal opinion is that it doesn't really come down firmly, and come out and say that it's lawful or unlawful. And I would say that it's a fairly, it's kind of a gray area in that. It is not prohibited under current law, and generally things that are not prohibited are authorized. But given the two previous Attorney General opinions and the provisions providing affirmative authorization, could some judge or could a judge perhaps read some sort of common law prohibition? It's not out of the question. But again, generally things that are not prohibited are authorized. So, I don't think that the law is 100% clear on this issue.
Thank you very much for that opinion. And I think if you get 5 attorneys in the same room, you're going to get 5 different opinions, right? That's why we go to court, and that's why we go argue, right? So I'm going to argue my interpretation is that because it's not prohibited, it's allowed.
So do we want to go ahead and let them answer first? Because
but you wanted him to answer a question, and so I'm responding to his question, if that's okay. And now I'll go ahead and follow up with my question that I asked before, Mr. Chairman. Is that okay?
Go ahead.
Thank you very much. So is the purpose of this bill, because of the cloudiness of this issue, to ensure that hospitals can hire physicians?
Senator Dagnotti, through you. Senator Stone, the purpose of this bill, in my opinion, is to pick up where the last AG opinion left off in 2010, which was, if you're going to change what's happening in Nevada, you should do it at the legislative level. So one way or another, we're in front of you because this is a legislative issue. And we would like, in this bill, to not allow more of anything until there's some statutory kind of like timeout with AB 11, and then this interim committee that can have a thoughtful discussion about what should the state want to legislate. Because right now, you're saying that it's gray, but really, I think the way, without some clarification, there will just be, in our opinion, messy situations where patients can't get care.
No, I respect that, but is the answer, I'm taking your answer is yes. You want to have clarifying legislation and statute that prohibits a hospital from hiring a physician. That, to me, is the purpose of this legislation, to eliminate the clouded areas that you brought up with the Attorney General's opinions collectively. Is that correct? A simple yes would be fine, or no?
Well, I think we want to take it to the interim study. We want to pause any more hirings. The hirings that have already been done. Pause those. And take this to interim health and have a more robust conversation about what the state of Nevada needs.
Thank you.
Mr. Chair, through you, if I can address Senator Stone's question as well.
Please proceed.
Okay. Mason Van Houweling, for the record, and Senator Stone, I always appreciate your perspective and your history and your business acumen. So again, I think to answer your question and follow up with Ms. Bond, again, we have 2 exceptions in NRS, and you don't have exceptions if you don't have something out there. And again, we're trying to bring clarity so we can bring this to rest around the corporate practice of medicine. So again, my thoughts are that you've got exceptions to some policies or laws, and again, we're just trying to, as the entire commission, again, it's just not Ms. Bond and I, it was unanimous that we had worked on this for well over a year to really understand. And then also, I appreciate the non-compete conversation as well. But again, I think moving this forward and getting it to the interim to continue to study this. But I do hopefully that answers your question, Senator Stone.
One more question from Vice Chair Nguyen.
Thank you. I appreciate that. I was thinking that Senator Stone, in his previous residence to the west of us, probably benefited from this, because I know for several years it has been banned there in that state legislatively. So just with that. But I guess my question to the capitalistic, comments of my colleague is it seems like without this, like in statute, you would have a situation where a hospital could contract with the only specialists, and then anyone that wants to like negotiate any kind of rates, just like in a capitalist market, they're going to charge a whole lot more because they know they are holding like the magic key to like health for like people in the community. So again, I'm very supportive of like any limitations that are placed in addition to some of the non-compete. I know I've heard from several doctors that actually are practicing out of the state because they have these non-competes that they can no longer do. So just want to put that out there.
Senator Lang.
Thank you. So my question is about the study group, and I understand the importance of the study group, but in the Senate, we get 3 study groups in the whole Senate. And so I sit on 3 committees, and in those 3 committees, I bet we've had 9 study group requests. And so I'm just interested in how you could see your bill proceeding if we maybe couldn't get a study group. Do you know what I'm saying? Because, I mean, I know it's part of your bill, and either we pass all of it or none of it, but it gets very complex when we deal with just a study group.
Yeah, and Senator Lang, maybe I can answer that, and we'll have Senator Carlson as well. The bill legislation, I believe, tasks it with the Joint Interim Health and Human Services Committee, so it wouldn't count as part of the 3 studies that we have. But unless Senator Carlton, if you have anything else.
No, Mr. Chairman, that's exactly it. Because it's cited in the bill, it would be tasked to that particular committee, and heaven forbid the bill doesn't quite make it to the finish line. There would really be nothing to stop the interim committee in discussing this, but we would hope that the other provisions would make it through, because we do think a pause needs to be had. And I've always felt like in legislation, when you have a list of exemptions, if that thing isn't in the exemption, then it isn't exempted. That's why this is really gray for us with all of these things. So I really think it would be great for the state to be able to say, docs, you have this contract, go forward. We're not going to get in the middle of your legal contract. But we'd like to take that pause, and we'd like to make sure that what we're doing moving forward is really what's best for the state. So that we thought was a real good way to address all the issues and not hurt anybody in the meantime. Because the last thing anybody wants to do is not have a doctor practice in this state. So it's all about making sure they can practice in this state.
Thank you. That's helpful to clarify that.
Senator Carlson, I have one philosophical question for you. It's not, yes, I usually don't have the opportunity to get the chance to ask a question to a lawmaker that has such institutional knowledge and from a historical sense that has shifted this body from making good decisions that affect people. So why is it important for our state as an institution to follow precedent? And in the circumstance that we had with a commission pushing forward a bill, coming to the legislature, I guess the question is, why is it important for our body to follow precedent that has been predicated from any of us serving in this body?
Are you, Mr. Chairman, and just for clarification, is this in reference to the 3 bills that came from the commission and actually having a hearing in this body and moving forward? This body, you 63, you gang of 63 have an awesome responsibility. You are now part of a very select club of people in this state that will make a difference with the children that are coming behind you. And, maybe it's just the Girl Scout in me, but you leave things better than you find it. When someone does the work and puts the time in, such as the Patient Protection Commission did, the bills were drafted, why not have the public discussion? Why not bring them to you? They've been discussed in the Assembly. They were voted out of the Assembly. They are now in the second house that's our process. You'll have these discussions and you'll move forward. If we're lucky, they'll make it across the mall to the north of you here, and who knows what the discussion will be there. But it's all about the 63 of you having thoughtful, deliberative discussions about every issue and not being told, or recommended, I'll say, that maybe this shouldn't be discussed by the legislature this time. Anything that comes forward should be discussed. As Senator Stone mentioned earlier, in another state, they hear every bill. I would not wish that on my enemy in this state. You only have 120 days. You only have so many brain cells, and you only have so many nerves left by day 119. I started in this building under the first year of the 120-day clock. It was not pretty, and I wouldn't wish it on anyone.
Thank you so much. With that, we'll move to testimony and
Mr. Chair?
support.
One more question, if I may.
We do have other bills on the agenda.
One
so
simple question.
Go for it.
Thank you, Mr. Chair. I appreciate it. Do you envision that this bill, if it were passed into law, would be applicable to ERISA-funded health centers?
So I will go ahead and answer that question. So the bill specifically outlines the circumstances and the exemptions. It follows what other laws have been passed in different states. So I do not believe that is an appropriate question for this. So we'll go ahead and move on to testimony and support. So if you have testimony and support, please come forward. And folks in Las Vegas as well. And once again, we ask folks to keep their testimony to 2 minutes so that we do have other bills, as we mentioned, on the agenda. We'll proceed. Ms. Magnus?
Good afternoon, Chair and members of the committee. For the record, my name is Annette Magnus, and I'm the Executive Director of Battleborn Progress. We are here in staunch support of AB 11 because the corporatization of healthcare is bad for Nevadans, and this bill addresses that by confirming the long-standing norm in Nevada against the corporate practice of medicine. Corporate practice of medicine can lead to decisions that prioritize financial interest over patient care. When medical decisions are made by non-medical professionals who are primarily concerned with profits, Nevadans that have to live with those decisions will suffer the consequences. Please support AB 11. Thank you for your time.
Good afternoon, Chair Donate and members of the committee. My name is Paul Catha, and I represent the Culinary Workers Union Local 226. The Culinary Union supports Assembly Bill 11. The Culinary Union, through the Culinary Health Fund, is one of the largest healthcare consumers in the state. The Culinary Health Fund is sponsored by the Culinary Union and Las Vegas area employers. It provides health insurance coverage for over 145,000 Nevadans, the Culinary Union's members, and their dependents. Through a vigorous engagement of members, the Culinary Union has maintained one of the strongest healthcare plans in the nation, with 0 monthly premiums, $0 deductible for covered services, and free generic prescription drugs at multiple culinary-free pharmacies across southern Nevada. Nevada is experiencing a severe physician shortage. Even though Culinary Union members have one of the best healthcare plans in the nation, when the providers are not present, Culinary Union members cannot receive the care that they deserve and need. Assembly Bill 11 will ensure that doctors have the freedom to see patients at whichever hospital they choose, and guarantees that doctors are free to make medical decisions as they see fit. Guaranteeing doctor independence from out-of-state hospital corporations will benefit all Nevadans, not just Culinary Union members. The Culinary Union supports Assembly Bill 11 and encourages the Nevada Legislature to support and pass the bill. Thank you.
Thank you, Chair Donate and members of the committee. For the record, my name is Susie Martinez, and I am the Executive Secretary Treasurer of the Nevada State AFL-CIO. And on behalf of over 150,000 members and 120 unions, we are in full support of the bill. I truly believe that capitalism can be good, but unfortunately, it's always on the backs of labor, and that's why we're having our nurses shorting. And let's not continue having the nurses shortage because of capitalism to come into this doctor shortage as well. Thank you.
For the record, my name is Mark Ellis. I'm the president of Communication Workers America. On behalf of our 700 members at St. Mary's Hospital, we support this bill.
Good afternoon, Chair, members of the committee. For the record, Randy Saltero, representing the International Alliance of Theatrical and Stage Employees. We are in support of this bill. Thank you.
Thank you so much. Anyone else in Carson City? Anyone in Las Vegas? And BPS, anyone virtually in support?
If you would like to testify in support of AB 11, please press star 9 to take your place in the queue.
Good afternoon, Mr. Chairman, members of the committee. For the record, my name is Liz Sorensen. That's L-I-Z, last name S-O-R-E-N-S-O-N. I'm the president of the Nevada State AFL-CIO. and I'm here today in full support of Assembly Bill 11, and I urge this committee to do the same. Thank you for your time.
Good afternoon, Chairman and members of the committee. For the record, my name is Dion Hoog, D-I-O-N-N-E-K-O-U-G. I represent the United Food and Commercial Workers Union at the 7-Eleven in Las Vegas, and we strongly support AB 11. Thank you.
Mr. Creel, you may speak if you'd like to.
Good afternoon. My name is James Creel, James. I represent Compassion Center, and Compassion Center is strongly in support of AB 11. Thank you very much.
Good afternoon, Chairman Donate and members of the committee. For the record, my name is Rita Weishar, spelled R-I-T-A, last name W-E-I-S-S as in Sam, H-A-A-R. I'm with the Nevada Alliance of Retired Americans. We are in full support of Assembly Bill 11 and urge the committee to support it as well. Thank you.
Caller ending in 348, you are unmuted and may begin.
Good afternoon, Chairman Donate and members of the committee. For the record, that my name is Clarence McCarthy, C-L-A-R-E-N-C-E, McCarthy, M-C-C-A-R-T-H-Y. I'm with the National Association of Letter Carriers, Brent 709 in Northern Nevada, and I'm here in full support of Assembly Bill 11, and I urge the community to support it as well to address the shortage of doctors. Thank you.
If there is any additional virtual support for AB 11, please press star 9 to take your place in the queue. Chair, there are no additional callers choosing to testify at this time.
Thank you so much. At this time, I'll invite everyone who would like to testify in opposition to this bill to please come forward. And we see some folks in Las Vegas, so please come on. And we'll start with Mr. Kelly. Yeah.
Good afternoon. My name is Susan Prophet. I'm the Vice President of the Republican Club. But I'm
Excuse me,
gonna
ma'am.
speak for myself.
Excuse me.
Excuse me?
We're starting with Mr. Pat Kelly up here in Carson City, and then we'll go to you, okay? I did ask
Oh,
Mr.
of
Pat
course.
Kelly
I
just to.
am so sorry.
You're okay. Mr. Kelly.
Thank you, Chair, members of the committee. My name's Patrick Kelly. I'm the CEO of the Nevada Hospital Association. We just heard a great presentation about the past going back to 1977, and what I'd like to talk about is the future and where we need to go. I know you're aware of the terrible healthcare statistics facing Nevada. We're near the bottom in access to healthcare. The large portions of the state are designated by the federal government as health professional shortage areas, and we have a shortage of all types of healthcare workers. Because AB 11 is about physician, I'd like to share a few specific matters. I'm sorry. Nevada needs more than 1,500 physicians to meet the national average. Nevada ranks 45th for active physicians among U.S. states. Nevada is below the national average in 33 of 39 physician specialties. In 25 of 39 specialty areas, the number of physicians did not keep pace with Nevada's population growth over the last decade. With these terrible statistics, I ask you, why would we do anything to impair our ability to recruit and retain physicians? AB 11 prohibits private hospitals in the state from employing physicians. This includes hospitals such as Carson Tahoe, Renown, the Dignity Hospitals, Sunrise, the largest Medicaid provider in the state, and many other hospitals, including rural hospitals. Hospitals are one of the primary recruiters of physicians, particularly specialty and subspecialty physicians. Why would we eliminate such a large number of hospitals from employing physicians when we have a shortage? AB 11 goes against all national trends. I told Destiny I could screw up technology without any effort. I don't understand why this isn't. Okay. So AB 11 goes against all national trends. The American Medical Association found that 2020 was the first year in which less than half of patient care physicians worked in private practice. Almost 40% of physicians worked directly for a hospital or for a practice that was partially owned by a hospital or health system. Only 1/3 of physicians under the age of 40 worked in a private practice. So why are we seeing this shift in practice patterns? There's several reasons. Many younger physicians leave school with large debt. They don't want to go to the bank and borrow more money to start a practice. They don't want to see patients all week and then spend weekends handling office matters. They want a work-life balance. They want to practice medicine, not run a business. Older physicians are tired of running their practices. They're tired of keeping pace with regulatory issues and the hassles of private practice. Many choose to be employed. The AMA has an interesting employment statistic. Women physicians and younger physicians are more likely than male physicians and older physicians to be employed. 56.5% of women physicians were employed in 2020. 70% of physicians under the age of 40 were employed in 2020. That's the key statistic. 70% of the physicians under the age of 40 chose to be employed. That tells you the trend and where we're going, or where we hope to go. Nevada competes with communities across the nation for physicians. We need every available employment option to entice doctors to practice and live in our state, including hospital employment. In our healthcare delivery system, hospitals are in the perfect position to identify community needs. When older physicians retire, hospitals search for replacements. Hospitals create and support specialized services such as pediatrics, pulmonology, stroke centers, and other specialized services. They also interact with many healthcare providers in their communities. Keep in mind that hospitals treat every person, documented or undocumented, who comes through their emergency department doors. Proponents of the bill have questioned the appropriateness of private hospitals employing physicians. They fear that hospitals may interfere with the physician's medical judgment. Hospitals do not control the clinical judgment of physicians. Hospitals separate the business functions of the hospital from the clinical functions using medical staff committees. These committees are organized bodies of licensed physicians and other healthcare providers who are permitted by law and by a hospital to provide medical care with the appropriate physicians are involved in all clinical aspects of the hospital, and the Joint Commission of Accreditation of Healthcare Organizations reviews the separation. We are unaware of any complaints filed or actions taken against a Nevada hospital or physician related to interference with clinical judgment. The AMA addressed this issue and stated that physicians should be free to enter into mutually satisfactory contractual arrangements, including employment with hospitals, healthcare systems, medical groups, insurance plans, and other entities. Earlier you saw a slide It was dated 2015. This statement is from 2020, just last year. The AMA would not make this statement if it feared hospitals would interfere with the clinical judgment of a physician. We find it a bit ironic that AB 11 allows venture capital funds to hire physicians, but not hospitals. Hospitals are licensed and regulated by the state of Nevada. Many have long histories of serving Nevada communities. Venture capital funds do not. It's counterintuitive to allow large private equity firms to employ physicians in Nevada, but prohibit Carson Tahoe, which is a hospital just down the street that's been a part of this community for decades. AB 11 was amended in committee to prohibit certain contractual restrictions between hospitals and physicians. Currently, some contracts prohibit hospitals from practicing at other facilities during and immediately after their employment. Reasons exist for these restrictions, including the fact that physician recruiting is very expensive. It can cost hundreds of thousands of dollars to bring a specialist to Nevada. Here are a few examples of the expenses hospitals incur. Hiring a recruiter, travel costs for the physician's spouse to visit the community, relocation expenses, which are substantial these days, housing assistance, sign-on bonuses, and income guarantees. You know, when we hire a physician, they don't start, producing money right away. A lot of times they have to get adjusted into the system. They may be waiting for their license to clear, and we're paying them. And we're guaranteeing their income, and they're not bringing in any revenue. And a lot of times it takes the insurance companies forever to pay, so you can be months before you see the first dollar on these folks. Hospitals invest hundreds of thousands of dollars to recruit a physician. A private equity group across town should not be able to hire the physicians away when they made no investment to bring that physician to the community. Hospitals need some type of protection if we want them to build specialty services. AB 11 allows public hospitals and academic institutions to employ physicians. Do they really have the capital needed to recruit and hire all the physicians Nevada needs? Doesn't it make sense to allow all hospitals, for-profit and not-profit, to use their capital to recruit physicians to the state? AB 11 takes Nevada in the wrong direction. Please vote against it. Thank you.
Thank you, Mr. Kelly. Vice Chair Nguyen, did you have a question?
Thank you. I appreciate that you have some concerns about other physician practices buying up, I don't want to say buying up doctors, but contractually obligating them and inhibiting that. But I feel like that's just like a whataboutism, that we're just trying to say we can't do this here because we're not doing it in other places. And we all know that legislation sometimes moves incrementally. But I guess my question is do you know when the hospitals here in Nevada started hiring doctors within, the hospital setting? When did they start this recruitment and investment and bringing people in and employing them in hospital settings?
Pat Kelly, for the record. Senator, I do not know when that began.
Okay.
But I think it's been around for a while.
Okay. And do you know how many doctors are currently employed, within the hospital system generally, amongst all of your members?
Pat Kelly, for the record. Senator, I do not know that.
Okay. I think it would be helpful if you can obtain that information for the committee to review as well. Thank you.
Mr. Chair?
Senator Stone?
Thank you. If I can follow up with our hospital representative. Thank you for being here, Mr. Kelly. One thing I heard today that I thought was a little bit outrageous is that a hospital would dictate the manner in which a physician would practice under their hire. Can you allude to the independence that a physician has to ensure that the patient is the primary interest and not the profitability of the hospital? Can you elaborate on what's in place to ensure that, please?
Senator Patrick Kelly, for the record. So there are a couple things. One is when you look at the regulations governing physicians in the state, it's very clear that they're not allowed to have anything interfere with their medical judgment. So that's number one, and they have to follow that. The second thing is the Joint Commission does come in and take a look at hospitals very closely, and one of the things they do is to make sure there's a separation between the business functions of the hospital and the clinical functions, and that's why we go through this whole elaboration on medical staffs, so that they are the ones who are creating and making the clinical judgments for the hospital.
Thank you so much. Sanitizer, do you guys have any questions? Oh, I just have one. So, you know, in terms of, and this is just me speaking, personal side, I've seen the non-compete agreements be egregious. I've seen entities here in Nevada where, and this is me speaking with healthcare executives, nurse practitioners, et cetera, where the radius is too big and they really are limited and they have to be forced to leave somewhere else, which is why I believe there should be an expansion of all of this to be covered in healthcare, not just in hospitals, because it is a pervasive issue of non-competes restricting providers, and what we don't want is a situation where they have to leave. Now, the conversation on the corporate practice of medicine, I think that is an open conversation that should be debated, where I think the question comes to, which is, as we're seeing the shifts of consolidation in healthcare, at what point is too much, right? I was sharing to our vice chair the easy example where we have, in some specialties, very, very limited numbers of specialists that operate in the state. And should that have been acquired, it's very easy. I mean, if there's 3 ENT specialists in Las Vegas, you could easily go up to them and you can acquire them. And there's nothing in law prohibiting the acquisition. I mean, part of it is, as my colleague mentioned, the capitalistic mind frame that exists. But when it's the healthcare delivery that impacts the patient itself, and when you can control market power to increase the costs, should that fall into the wrong hands, for instance, in venture capitalism or private equity, that has some level of ramifications to how healthcare delivery is occurring. And so, having said that, I know that many states operate already under this corporate practice of medicine doctrine, where they have established that hospitals themselves cannot control or employ physicians. So I guess the question is, you know, what would be the problems that you're facing if simply everyone is done through the contractual basis versus the employment basis? Are there services that can't be delivered because of that distinguishment? Should we adopt this policy? I mean, I think that's kind of what we've seen in other states. So if you can touch point that, that'd be great.
Pat Kelly, for the record. Senator, you asked a lot of questions there, so I'm going to kind of parse this through. The issue with, first of all, I think no one really sits down and says, how do physicians come to the state? You know, physicians don't send a resume in and say, hey, I'm, a board-certified cardiovascular surgeon, and I want to come to Nevada. You go out and search for these physicians, and there are hospitals all across and communities all across the country who are searching for these physicians. So it's very competitive. So when you bring them in, as I said in that slide, they want housing assistance, they want moving expenses. The biggest thing is they want income guarantees, and that's incredibly expensive. So if the hospitals aren't the ones putting up the capital to do that, my question is, who's going to do that? What I'm fearful of this bill is that we're going to get to a situation where there's no one doing that, and you're not going to see any more specialists being brought into the community. And that's the danger. You know, we talk about, well, we're going to have this interim study to look at it. Why are we taking the action before we've had the thoughtful conversation of where the private practice of or corporate practice of medicine is going? You know, we should have the discussion and then do it. You know, on the PPC, I was on an advisory committee. We never met. So it was asked, well, when's the advisory committee going to meet? And then the answer was, after we get our work done. That's just crazy. You know, the advisory committee should have been offering their opinion. Now, I'd got 2 minutes every month to make a statement, and I took that, and I would write letters. I don't know if anybody ever read them. But there wasn't this input that I think really should have occurred.
Thank you for that. And I do want to go and proceed to the following testimony. I will ask if you can make sure that within the near term, since we are having this conversation now, that we can get the data points from the members as to how many of them they actually do employ. I think that would be helpful for us. And I think that's an important conversation just in general in terms of the data points. But we'll go ahead and proceed with testimony. Mr. Ross, please begin.
George Ross on behalf of HCA, Sunrise Hospital, Mountain View Hospital, and Southern Hills Hospital. To begin with, HCA does not hire very many doctors, but we hire the doctors directly that we need to hire to get them here. Not one of our people that we have got would be in this state if we hadn't directly recruited them and employed them. And the answer to the number is 16. There were 6 at Sunrise and 10 between the other two, plus one person running the GME program. Now, this is probably true of all the other hospitals too. So if we focus only one hospital where these people can work, what about all those other hospitals throughout the 2.3 million Clark County? How can they provide the same level of specialists and services? Because this is how you get these very specialized high-end people to come to this state. If you want them, we need to continue to hire them. As a point, parenthetically, we have no problem with nearly all of that amendment. We don't say you can't work at another hospital. We have had people who do that. We don't have a problem with the non-compete clauses. There's one place we do, and Mr. Kelly alluded to that. That 2-year moratorium on hiring should not be there. That basically says for 2 years, you have to stop improving, you have to stop adding high-end services, and you have to stop replacing anybody who you lose that you currently have. Now, you know the role of Sunrise. It was very interesting when we heard about UMC being able to hire doctors because they're a safety net hospital. Let me tell you what's a safety net hospital. It's a hospital that serves 25% of all the Medicaid patients in Clark County, not 13.8%. That is a safety net too, but the bigger one serves 25. It's a hospital that had 60% of its ER on Medicaid. Another 13% are uninsured. That tells you who that hospital serves. And we are told we're not going to be able to continue to offer high-end services. Right now, if we could not hire those doctors, you would not have the stroke center. There'd be one stroke center probably, and it'd be right upwards at UMC. Every second, every minute counts as to whether you survive a stroke and how you come out of it mentally and physically. Similarly, half our pediatric open heart surgeries could not take place because we have 2, and one of them is a directly employed doctor. The other one has been totally subsidized by his practice because he couldn't make this many Medicaid kids. He was just killed financially. So, what happens to those parents? They all have to make a choice because that child has to go out of state. They have to make a choice. Do I quit my job or do I go with my child? So that is, we understand.
Mr. Ross, if you can finish your statement,
yes,
please,
I
sir.
will. This is just going exactly the wrong direction. We are not doing what the other side said, which is providing more choices. You are taking away choices because the only place you can get these high-end guys will be those who may be able to go there. And I will add one more thing, which is a little bit unrelated. We also have a very large GME program. And if you need to have directly employed doctors for your GME program, why is it that we have the same considerations that UMC does as well? So can I just read 4 lines more? Do you mind?
We do have to move on to other testimony, but you can please submit that. We'll be happy to take your comments offline. Thank you so much, Mr. Ross. Ms. Watkins.
Thank you, Chair Donate and members of the committee. My name is Sarah Watkins. I represent the Nevada State Medical Association, and we're here in opposition to AB 11. The Nevada State Medical Association is the largest physician-led advocacy organization in the state. We advocate and share this committee's goal to attract and retain physicians in Nevada. Nevada must be able to compete with other states to recruit and retain physicians. Hospitals in many other states employ physicians. Our hospitals should be able to do the same. Because AB 11 does not improve access to care and does not support our shared goal of improving access to care, we are opposed. Thank you.
Thank you, Chair. Dan Musgrove, representing the Valley Health System of Hospitals. I think many of the questions today have been exactly what we should be debating today. Should hospitals be allowed to hire physicians or should they not? That's what this bill is all really about. It's a yes or a no. And we believe that the argument should be yes, for all the reasons that Mr. Kelly and Mr. Ross talked about. You've got to understand that the Valley Health System provides GME. Mr. Ross touched on it, but we're talking about students learning to practice in internal medicine, family practice, general surgery, psychiatry, orthopedics, pulmonary, neurology, and emergency medical. What happens when those doctors are ready to graduate and they want to stay in Nevada, but as that statistic showed, they want to be employed, and we have to say to them, sorry, we can't employ you. What happens when Dr. Titus decides that she wants to go work for somebody because she can't be in private practice anymore, and we say to her, sorry, Dr. Titus, you can't work for a hospital. You have to survive on your own. We cannot remove this tool from our toolbox because, again, we're last in everything. Obviously, what's going on now isn't working, so why do we not continue to at least try to expand this attraction of the people that we need to practice in this state so we don't have to go to the airport? Thank you, Senator.
Thank you, Chair Doniate and committee members. Misty Grimmer representing North Vista Hospital. I won't repeat a lot of what has already been said. We also are in opposition to this bill. North Vista is the only hospital in North Las Vegas. I don't think a lot of people know that. And we are not exactly in the fancy part of town. So it's important to us to be able to have every tool in our toolbox to be able to bring docs to come practice in our facility. Thank you.
Good evening, Chair, members of the committee. Paul Marakin with the Vegas Chamber. The Chamber continues to be opposed to AB 11. Chamber had concerns with the original version of the bill and continues to do so with the amended version with the non-compete provisions in Section 7 of the bill. We believe this bill will not help retain doctors in Nevada, but rather cause additional stress on our healthcare system in our hospitals and care for our Nevadan citizens, especially those that need specialized medical care in the hospital setting if these doctors leave our state. Thank you very much.
Thank you so much. Anyone else in here in Carson City? Let's go to Las Vegas. Ms. Profit?
Oh, goody. All right. My name is Susan Profit. I'm the Vice President of the Nevada Republican Club, but I'm going to speak for myself because I'm not sure if they all agree with me or not. I have a feeling they do. First of all, I sent up a copy of my Silver State insurance card for you all to see, and there's something very odd about it. They assigned me to the Desert Valley Pediatrics at the age of 63 because we don't have an infrastructure. And unfortunately, with the new immigrants coming in and getting Medicare for all, if you all pass that bill, it's going to implode what we already have. And so, and I'm also a
Ms. Profit,
retired,
are your comments relating to AB 11?
Excuse me, I am, and I'd like my
Okay.
time back. Excuse me, I am. I am a recruiter. If you'd like to know how much it's going to cost you per doctor to hire them, we charge 25% of their placement fee. So the average cost is going to be, just for the lower levels, $25,000 to $75,000 apiece. For a specialist, you're going to pay anywhere from $100,000 to $200,000 minimum per doctor if you have to hire a recruiter. So and by the way, I think it's unconstitutional that you pick and choose which hospitals are going to be able to hire doctors. We need all the hiring professionals we can get right now. That is not an easy thing to do, to talk doctors into coming to a state that doesn't even have a decent education system for them. And by the way, the figures were wrong. It's 49th in the United States for numbers of doctors. So we are desperate. And and by the way, in addition to me being assigned to a pediatrician at 63, my husband is now dying of lung cancer because he had to wait a full year to get in for surgery. And he refused to go back to Florida to have the surgery done. And so I really think you need to fix this bill as fast as possible. I mean, just chunk it, because we need to hire as many doctors as possible before anybody else dies. And there's one last thing. Since you were rude to me, I'm going to point out, it is troubling that you were rude to both of the objectors, and they were conservative senators. I really am offended by that behavior, and I wish you'd stop. Thank you very much for your time. I will vote the way my senators vote.
Thank you, Ms. Prophet. Next speaker, please.
Good afternoon, Chair Donate and members of the committee. For the record, my name is Dr. Irene Gutierrez, IRENE-GUTIERREZ, and I'm the Program Director for Family Medicine and the Associate Designated Institutional Official at Dignity Health, St. Rose Dominican in Southern Nevada. I've spent my career training physicians and working to bring additional primary care physicians to areas like Southern Nevada. Dignity Health St. Rose Dominican is the only not-for-profit faith-based health system in Southern Nevada, and we will be adversely affected by this bill. The ramifications of the bill are significant. First, AB 11 will decrease access to care for Nevadans. Hospitals are one of the primary recruiters and employers of physicians, especially physicians who are specialists. We will begin to lose services and will be unable to expand access to services. Second, passage of AB 11 will hinder our physician recruitment efforts because nearly 3/4 of all physicians want employment options. Many new medical school graduates prefer employment because they want to practice medicine, not run a business. The Nevada State Legislature has introduced several great bills this session incentivizing medical students and other physicians to come to Nevada. AB 11 would reverse all the good work being done in this area. If AB 11 passes, we may lose the physicians we currently employ. Finally, if AB 11 passes, it would also prohibit physicians who would have been employed by a nonprofit like us from qualifying for federal student loan repayment programs through the Public Service Loan Forgiveness Program, which requires employment by a nonprofit. All of the high-quality health systems that people leave Nevada to receive care at in the United States employ their physicians. Health systems like Mayo, Cleveland Clinic, and Cedars-Sinai would not be where they are today without the ability to manage their clinical workforce. Other states that had laws like AB 11 have either removed the law or passed significant workarounds like California's foundation model. AB 11 is a bill in search of a problem. We don't need it, and it will make a really bad situation in Nevada even worse. Please oppose AB 11. Thank you.
Thank you, Chair Donate and members of the committee. Emily Osterberg, OSTERBERG, on behalf of the Henderson Chamber of Commerce and our over 1,800 members, most of which are small businesses, and I'm here to express our opposition to AB 11. Nevada already has a severe shortage of physicians, and our state ranks last in almost every access to health care category. Banning hospitals from being able to employ physicians for 2 years will make it more difficult for hospitals to have adequate staffing. This is detrimental to an already fragile healthcare industry in the state. For these reasons, we are opposed to AB 11. Thank you.
Thank you, Senators, for your time. Dean Pols, D-E-A-N, last name Pols, P as in Paul, O-L-C-E. I am actually one of the people you guys have spoken about today. I am a specialist. I am a cardiac anesthesiologist. Many references to cardiothoracic surgeons. I know all of them in Southern Nevada, and many of them are employed. They were in private practice when they came to town, and much like Dr. Titus, they could no longer handle the work pressure of running a business, so they went into employed model. So we need this option, and for my specialty specifically, employing anesthesiologists by hospitals right now is an incredibly popular trend around the country. This has a lot to do with the distortions of Medicaid and Medicaid rates that hasn't changed since 1984 and 1991 respectively. The irony of the bill, and I want to speak to Mr. Von Holling before about being exempt from this bill. University Medical Center is very much overpaying. This is a price issue, very much overpaying for services that all of us render at a much lower cost. So working 2 weeks on and 2 weeks off is not fair market, is not how any of us work. It leads us to access to care issues. As far as aggregation goes, centers of excellence exist in our specialty for a reason, because they do a ton of volume. Cleveland Clinic Foundation does 5,500 carts a year. That is a stunning number. If I was going to have heart surgery, I would want to go there. So if you want more better care, you want centers of excellence, you want them aggregated. As far as the comments on non-compete, the people who are complaining about the non-competes, by and large, wrote them themselves and ignored them themselves. So the hospitals are not having us sign these. The anesthesiologist specifically in question wrote them and ignored them themselves. So if they're such bad things, they shouldn't have put them to law to begin with, or shouldn't have signed a contract or forced other people to sign them. They're not set by radius, they're set by referrals and facilities. Please oppose this bill. There are other options. But as far as training residents, our group trains the only anesthesia program in the state. Thank you for your time and consideration.
Thank you so much, sir. Anyone else in Las Vegas? BPS, anyone virtually?
If you would like to testify in opposition to AB 11, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. And anyone else willing to testify in neutral on this bill, please come forward. Seeing none here or in Las Vegas, let's go to virtually.
If you would like to testify in neutral for AB 11, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. And I'll invite the presenters back if they want any closing comments.
Thank you very much, Mr. Chairman, for the opportunity to present AB 11 to this committee. And thank you for being the type of chair that maintains some control and keeps direction straight at the bill. I think this bill and this conversation really proves why we need a PPC, a Patient Protection Commission, that's viable and doing its job every 18 months, because healthcare issues are passionate issues, and we need a group of professionals that sit around the table, that look at the data and have the conversations and narrow the scope and bring these very important issues to this legislature so that you could try to address these public policy issues in the limited 120 days that you have. So thank you very much. I appreciate all sides of this argument. I think what was done in Assembly Health and Human Services, instead of having a total prohibition, going to a 2-year pause and studying it, might be able to get more people at the table and be able to come to some more agreement. I heard a statement earlier about another possible exemption that I didn't realize existed. The more we discuss this issue and collaborate on it, hopefully we'll come up with the best policy for the state. And that's what it's all about. Thank you.
Thank you so much, Senator Carlton. We greatly appreciate you coming back. And I want to thank my colleagues for their line of questioning. We understand that this is a difficult issue, and that's why we wanted to make sure that the Hospital Association and the opposition got some fair time as well to speak. And so we'll go ahead and close the hearing on this bill, and we will move on to Assembly Bill 206. We have with us Assemblywoman Brown May, and this bill revises provisions governing the Nevada Commission for Persons who are Deaf and Hard of Hearing. So please begin when you are ready.
Thank you, Chair Dunyate. Members of the committee, for the record, my name is Tracy Brown May. I'm the Assemblywoman currently representing Assembly District 42 in Clark County. We are very pleased to be here this evening. Now, I'm honored to have the opportunity, and we sincerely appreciate your time and energy in hearing this bill. I would like to introduce to you to my co-presenter, Justice Forrest. Justice is my legislative intern, has been with me throughout this session. He's a student at the University of Nevada in Reno, and he'll be presenting Assembly Bill 206 to you today.
Thank you, Chair Dunyate and members of the Senate Committee on Health and Human Services. For the record, my name is Justice Forrest, and I am a student at UNR and a legislative intern this session. Out of respect for your time, I'll try to keep this brief. I'm here today to present to you a bill that was created out of a need for members of the Nevada Commission for the Persons Who Are Deaf and Hard of Hearing. The mission of the Commission is to ensure that all Nevadans have equal and full access to resources, services, and opportunities in all aspects of community life. Currently, there is no seat on the Commission reserved for an ASL interpreter, and this presents a lack of representation and support for the very community the Commission seeks to serve. While preparing for this bill hearing, I learned that for many in the deaf community, ASL is their language and acts as a key pillar of deaf culture that is central to their identity. ASL interpreters are a vital component in ensuring access to all aspects of public life for deaf individuals, and as such are an accessibility afforded to the deaf community under the Americans with Disabilities Act. Throughout the interim, the Deaf Commission conducted a series of town hall meetings with the deaf and hard of hearing community throughout the state. One of the most consistent points of feedback was that there is a significant deficit in both the number and quality of available ASL interpreters. The state has taken several steps to address this deficit, such as revising the Nevada Administrative Code to increase the standards for working as an interpreter in the state. However, we still need to improve resources to support the pool of interpreters working in the state. There are limited opportunities in Nevada for training new interpreters or building skills among currently registered interpreters. The Commission has emphasized the need for input from someone who is registered with the Nevada Registry for Interpreters for the Deaf, which is maintained by the Communication Access Services Program in the Aging and Disability Services Division. Section 1 of the bill amends Nevada Revised Statutes 427A.750 to increase the number of members on the Nevada Commission for persons who are deaf and hard of hearing from 11 to 12. Section 1 also requires that this newly added member serve as an ASL interpreter as recognized by ADSD. Section 2 allows the governor to appoint the new member after July 1st, 2023, and Section 3 makes this bill effective on July 1st, 2023. Thank you for considering AB 206, and we are happy to answer any questions.
Thank you so much, Senator Titus.
Thank you. Thank you for being here. Thank you for the presentation. Sorry about the, there's only a few of us, but we're mighty, and we care. I took a sign language class in college early on and was able to use it. And of course, like any other language, if you don't keep using it, you forget it. My question, according to the notes from the previous testimony and at previous hearing, and I think it's not correct, you're only going to require that this new commissioner is the person that knows sign language, correct? That not all the commissioners have to know sign language?
That is correct, yes.
Okay, thank you, because in our notes it says...
For the record, Justice Forrest.
Says that. And also, I have some concerns. I have a bill in AJR 1 that has passed out of both, houses. I've worked on it for 5 years to take the term deaf and dumb out of our Constitution. And one of the things that the folks that worked with me on that bill, a family with children that have issues with hearing, they read lips and they have implants but they don't know sign language. So I want to make sure that we're not just focusing on sign language as a need for the hard of hearing.
Thank you, Senator, for the question. Assemblywoman Tracy Brown May for the record. I sincerely appreciate that, and in no way would we focus on one method of communication. In many of the interim meetings, we hosted many members of the deaf and hard of hearing community, and there are many ways that we communicate. My husband is also hard of hearing and utilizes captioning as his preferred methodology. And so adding choices to how people communicate is the most advantageous for all of our citizens. In the meetings in the interim, it was identified by the members of the Deaf Commission that this one piece, this one member was missing from their ranks, and they felt like it would be advantageous to add that perception in to the existing membership that was already there.
Any other questions? Let's move on to support testimony. If you are here in support of this bill, please come forward here in Carson City. Seeing none, I think I see someone in Las Vegas, so please proceed. Please proceed.
Yes, this is Eli Schwartz for the record. I am a commissioner for the Nevada Commission for the Persons Who Are Deaf and Hard of Hearing. Thank you, Mr. Chair, and the member of the committee for allowing me to make a statement in support of this bill. Just to remind you, the Nevada Commission is tasked with making recommendations to the state of Nevada concerning the establishment and the operation of the program for the persons who are deaf, hard of hearing, or speech impaired. As you know, the Commission would like to add another seat to the Commission. This seat will be filled with a person who is certified sign language interpreter that is registered in the state of Nevada with a proficient experience and knowledge of K-12, post-secondary, and freelance interpreting services. By adding this seat, they will enable the Commission to be informed of any interpreting issue. There is a high need of interpreting here in the state of Nevada. So by being directly connection to this portion of our community, the one that use sign languages, it will allow the Commission to make informed decisions and make recommendations to the governor for statewide provision and bill needs. Again, thank you for allowing me to say my support.
Thank you so much. Anyone else in Las Vegas? BPS, is there anyone virtually?
If you would like to testify in support of AB 206, please press star 9 to take your place in the queue.
Good afternoon, Chair Doniate and members of the Senate Health and Human Services Committee. My name is Catherine Nielsen. I'm the Executive Director of the Nevada Governor's Council on Developmental Disabilities. I want to start with deaf interpreters are linguistic experts that ensure people who are deaf, hard of hearing, or those who use sign language are afforded full and equal access to services and supports in the community. A deaf interpreter is a specialist who provides interpreting, translation, and transliteration services in American Sign Language or other visual and tactical communication forms used by individuals who are deaf, hard of hearing, and deaf-blind. As a deaf person, the deaf interpreter starts with a distinct set of formative linguistic, cultural, and life experiences that enables nuanced comprehension and interaction in a wide range of visual language and communication forms influenced by region, cultural, age, literacy, education, class, and physical, cognitive, and mental health. These experts, coupled with professional training, give the deaf interpreter the ability to effectively and successfully communicate across all types of interpreted interactions, both routine and high risk. An interpreter facilitates communication between people who do not share a common language. Sign language interpreters are knowledgeable in the languages and cultures of deaf and hearing people. We, as the council, hosted a series of town halls across the state of Nevada in conjunction with the commission for persons who are deaf and or hard of hearing. And during our town halls, there was an overwhelming number of comments about the need to increase the number and quality of interpreters available in the state of Nevada. There's a lack of representation of these professionals, and by ensuring their seat on this commission, there will be the opportunity for increasing the number of interpreters and setting guidelines that improve the quality of certified interpreters in the state. Thank you very much for your time.
Good evening, Chair Danyate and the rest of the happy, healthy, and energetic committee. My name is Dora Martinez. I represent the Nevada Disability Peer Action Coalition, and I want to ditto the prior commenters and thank and thank Assemblywoman Tracy Brown May for sponsoring this bill. I'm sorry it's late, and we wholeheartedly agree with what's been said prior. Thank you. Have a good night.
Good afternoon. My name is Beth Jones, and I am in support of AB 206. As a mother of 2 kids who are deaf and hard of hearing, who many of you have met or heard testify over the years, I am also the executive director of Nevada Hands and Voices. I have been attending town hall meetings and deaf commission meetings for many years, and I now sit on one of its subcommittees. While my own children use spoken language and do lip read, like Senator Titus referred to, I have seen firsthand the needs for qualified interpreters to sit in leadership positions to help contribute to the community they serve. We need professionals with expertise in sign language interpreting, as well as someone who has the experience and knowledge of interpreting in primary, secondary, and post-secondary educational settings as part of this commission. With many other benefits that they would provide the entire deaf and hard of hearing community, without this crucial part of the team, we cannot improve the future of education in Nevada for generations of deaf and hard of hearing children. Thank you for your time.
Chair, there are no additional callers for testimony at this time.
Thank you so much. Let's move to opposition. Anyone here? Anyone in Las Vegas? I see a person. No?
Excuse me. Good evening, Chair, members of the committee. My name is Timothy Eliado. I'm representing Rare Disease Foundation. I'm a rare disease advocate, and I would just like to basically, I would just like to ditto the previous sentiments and comments by the previous speakers. Representation matters, and I hope that SB 206 passes. Thanks for your time. Thank you.
Thank you so much. If there's anyone else in opposition, I believe that was in support. Yeah. That was in support, but if there's anyone else in opposition, BPS, anyone virtually?
If you would like to testify in opposition to AB 206, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. And moving on to neutral. Anyone willing to testify neutral? Seeing no one here. Anyone in Las Vegas? And BPS, anyone virtually?
If you would like to testify in neutral for AB 206, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Assemblywoman, any closing comments?
Thank you, Chair. Assemblywoman Tracy Brown May for the record. Thank you for hearing this bill. We hope that we're really quick. I just want to get on the record before we close out. We did attempt to get a sign language interpreter to participate in this meeting for us today, as we knew we were going to have a number of members from the deaf and hard of hearing community joining us. We were not successful in that effort, and so we have a little bit of work to do. We'll continue to progress.
Thank you so much, Assemblywoman. I echo your sentiments. I think there's an important conversation of infrastructure in general for language access, and then I will commit to working with you on that. We'll go ahead and close the hearing, and then we'll move on to Assembly Bill 411. This bill revises provisions requiring certain medical facilities to allow certain patients who are terminally ill to engage in the medical use of cannabis. We have Mr. Horn here, so please begin when you're ready.
Good evening, Mr. Chair, members of the committee. Thank you for your time. For the record, my name is William Horn with Strategies 360 and representing Compassion Center on the presentation of Assembly Bill 411. We were supposed to have Mr. James Creel here with us in person today, but he had a mishap with his automobile in Tonopah and was towed back to Las Vegas, so he will be on Zoom. Also with some other subject matter experts, they're also on Zoom. I will read who those will be, and let Mr. Creel after that give the presentation on why this bill is here. And after we do that, I will walk the committee through the bill. Okay. On Zoom and ready to answer questions is Ken Zobel. He's an attorney who specializes in cannabis law. We also have Heather Manis. She's an RN, hospice nurse with an expansive background in cannabis and cannabis-related therapies. Aaron Hickey, also an attorney, was working for Senator Jesus, sorry if I mispronounced that, as a communications director who also had direct knowledge of interactions between the federal government, CMS, and HHS. Dr. Larry Bedard, emergency physician, trustee of the California Medical Association, and Julie Monteiro, RN, pediatric ER trauma nurse, medical educator, former HCA Joint Commission liaison, and current president and education director for the Integrative Providers Association. Ms. Monteiro also has a basic course and a master's course that has been AMA PRA Category 1 accredited through the UNR School of Medicine and offers up to 6 credits on cannabis, the plant safety considerations, its dosing, pharmacology, nutrition, and addiction. With that, Mr. Chairman, I'd like to pass this on to Mr. Creel, and he can give testimony on why this bill is here today.
Please proceed.
Thank you. And greetings, Chair Donate and Vice Chair Wynn and other esteemed committee members. Thank you for the opportunity to present to you and your committee such a noble cause. AB 411, or Ryan's Law, to share with you why it is so important for all of us to support such a bold step in the advancement of compassionate care for Nevada's terminally ill. As a member of Ryan Bartel's continuum of care, I take personal ownership in this bill and look forward to helping you in the state of Nevada adopt and even implement this first logical step into reintegrating cannabis back into mainstream medicine, right where it historically belongs. I want to start off by saying that after 25 years in the field, excuse me, after 25 years in the field of cannabis research, having the ability to remain a perpetual student definitely has its advantages, so please let me know how I can help you along your journey of discovery. You never know what you might learn. I recognize that while some people see me as a subject matter expert in one topic or another, I don't see myself as an expert in anything. I actually try to make it a deliberate point to learn something new about my subjects of interest almost daily. And I truly feel that I wouldn't rely so much upon so many of those who are the experts if I was truly one of them. I'm a career administrator and I run a tight ship. That part is essential to balancing the scales between accountability and compassion. So I totally understand the concerns that have been expressed. However, having laws like this on the books allow administrators like me to breathe easy when doing the right thing for patients under our providers' care. The bill we're proposing provides us a solid foundation. While it isn't actually mandatory, it leaves it up to the patient's families to enforce, and we all know how hard that can be. Excuse me. In that, AB 411 shouldn't be viewed as anything more than a much needed first step to the provision of the necessary framework for us to succeed. Passing AB 411 provides the ability to help those who are truly suffering while promoting the encouragement of a facility to adopt it through provisions in the law that specifically protect the administration and providers and the facility itself from penalties as a result in delivering the program. California's Ryan's Law has been slightly amended from its original draft by its original sponsor, Senator Ben Hueso, when he brought forth Bill SB 988 of the 2021-2022 session. Those modifications have been added as an amendment in cooperation with industry stakeholders to bring this bill into alignment with what was recently passed into law in the state of California. The intent was to repeal the actual requirement that healthcare facilities that are permitting patient use of medical cannabis also comply with other drug and medication requirements as specified. We support the entire amendment with the exception of the changes in the effective date and the omission of hospitals. Consider the patients who will suffer between July 1st, 2023 and January 1st, 2024. And removing hospitals would defeat the purpose and original intention of the bill. When this bill becomes law, it will require a healthcare facility to require a patient or a primary caregiver, as defined, to be entirely responsible for their acquiring, retrieving, administering, and even removing of medical cannabis. And it will require medicinal cannabis to be stored securely at all times. The law will require the patient and or the patient's primary caregiver to, upon discharge, remove all remaining medicinal cannabis. And if a patient cannot remove the medicinal cannabis and or does not have a primary caregiver, requires the storage of the product in a locked container until it is disposed of as specified. Compassion Center and the Integrative Providers Association feel that this bill should become law, should not only be adopted and fully adapted to fit Nevadans' otherwise unique needs, but we feel it would be a very logical next step for such a positively disruptive state like Nevada to take. By the way, congrats on 14.5% and such a low margin of uninsured citizens, regardless of where things stand today. But I digress. Back to AB 411, I would like to elaborate that while I fully understand the administrative benefits of having someone bring in their own lockbox, that lockbox becomes a target, and in my opinion, a real liability, and is subject to theft and diversion to the illicit marketplace when bolted down lockboxes can be protected. In leaning towards closing, Chair Donate, Vice Chair Nguyen, my staff and I appreciate the opportunity to work with you and your committee to explore additional possibilities beyond AB 411 or Ryan's Law, as long as they lead to a more compassionate tomorrow. In the meantime, we are looking forward to helping you and your committee facilitate, implement, and even adopt AB 411 in Nevada's 82nd session and set the first paver in the next logical pathway towards measurable and positive change for our terminally ill. To reiterate, the Compassion Center and Integrative Providers Association feel this is an essential step that we all need to realize in regards to improving end-of-life outcomes for patients in an inpatient environment. To me, there's no greater expression of outward-facing love or compassion than improving the quality of life for those who are facing terminal illness. And we intend to spread compassion to those having been forced into a hospital or other inpatient environment just to get much needed care if and when they would really be at home, really rather be at home. If you really think about it, nobody really wants to be admitted to a hospital and nobody wants to suffer. So why do those who are admitted to a hospital or hospital-run hospice center have to suffer when hospitals too are obligated in their certificate of need to alleviate the very suffering that they are imposing through outdated laws, policies, and procedural mitigation of liabilities and or aversion to red tape? They all lead to the same place, needless suffering for those who are already suffering enough. Let's end it now. Let's work together to break these barriers and redirect our policies in Nevada towards compassion. In service to the greater good, I am at your disposal. My name is James Creel, James Creel. I am the Secretary Treasurer for Compassion Center and Integrative Providers Association, and I close. Thank you.
Thank you so much, Mr. Creel. In the interest of time, can we go ahead and proceed to questions, if that's fine?
Yes, Mr. Chairman, your committee.
Thank you so much. I just wanted to double check that if we didn't miss anything. I know you were going to walk us through the bill, but seeing that most of us have already read the bill, and we found that there was a conceptual amendment proposed as well, so we have questions on it. So I'll start with Senator.
And if I may, Mr. Chairman, just for purposes with questions, I think Mr. Creel would be best at who to direct that subject matter expert to answer specific questions. So
direct them to Mr. Creel first, in case if he has to delegate it to other folks.
Yeah, and also that that amendment that was mentioned by, I think it's from the Nevada Hospital Association, and if it wasn't clear that the client has agreed to accept that amendment with the exception of the exclusion of hospitals out of it and the implementation date from July to January 2024.
Okay, thank you so much. Senator Titus.
Great, thank you. So then if it's okay with the Chair, I have a couple questions, and then maybe the sponsor of this, which should come up too, so I could question them. Would that be all right, Chair?
Let's
first let's do with the-
let's do the original bill first.
Great, perfect.
So that we can direct questions to Mr. Creel, and then if we have questions on the amendment, we can have those as well. So go for
It's
it.
good to see you, sir. Thank you for being here today. I as a medical provider, somebody who was a medical director of a long-term care for almost 40 years, not quite, I've never allowed patients to bring in their own medication. The concern is that it might interfere with something that we're prescribing for them, and not knowing certain drug interactions. It was always one of the first things in the ER or when I admitted them to the acute facility, and certainly in the long-term care facility, they could never bring in their own medications. So how would this be different, meaning that the risk of interference with other medications that I'm prescribing, perhaps not knowing that they're taking it, or even if we did know, it would just be counterintuitive to allow them to self-medicate?
Mr. Creel?
Thank you very much, Senator Titus and Chair Donate. So first off, cannabis does not compete with the same receptors as the opioids. So, and it competes with very few other receptors since it has its own receptors, the CB1 and the CB2. CBD even binds with the fatty acid amide hydrolase, suppressing it and allowing your body's own endocannabinoid system to engage. So there's not very much concern on the contraindications from what we've learned and from what we've also compiled into a course on the subject. However, I would like to defer to Dr. Bedard if we could, if he's still here, to potentially get that question answered. If not, potentially Nurse Julie,
Well, I'll tell you, why don't, in the interest of time, let's move on. As a doc, I know the pathways here. The next question I have is the logistics of the lockbox. And so when you have to, number one, it's still outlawed federally. And so as hospitals have Medicare monies coming in, we're still followed by CMS and potential issues concerning that regulatory process. How does the California Institutes resolve that potential issue with CMS and allowing this Schedule 1 drug to be in their facilities?
I would like to divert that to Ms. Erin Hickey, if I may.
Hello, Chair and Senators. Hi, my name is Erin Hickey. I'm here in a personal capacity today, but I was formerly a California State Senate staffer, and I worked for Senator Ben Wesso, who carried the original version of this law, and I was the lead staffer on that. So really the only true opposition that we ever had to this bill was regarding the fear that facilities may lose their CMS funding if they were to participate in this. In fact, the very first time that we tried this bill in 2019, Senator Stone was one of our co-authors. It was vetoed because of this fear. Subsequently, in 2021, I reached out personally to CMS and inquired about how they would treat the activities under this bill, and they replied in writing that the Medicare and Medicaid regulations do not address medical cannabis at all. They don't even mention those words.
All right, thank you. And then final question, if I might, Mr. Chair. So one of I have prescribed Marinol in the past, and it seems like if a patient certainly comes in, the family has requested, or the patient requested the use of the THC, Marinol seems like a more logical pathway that we don't have to worry about it being so controlled in its own lockbox. And so was there any discussion on the California pathway about Marinol?
Thank you very much, Senator Titus and Chair Donate. I would like to first say that Ethan Russo, the doctor who's one of the most notorious researchers behind GW Pharmaceuticals, the manufacturers of the counter version, which is Epidiolex, he has published numerous papers about the efficacy of the entourage effect for cannabis as a whole plant. Marinol is specifically a synthetic version of THC Delta 9. And thankfully, we've had a broad range of research start to emerge over the past few years, and there's several other cannabinoids that work better than Delta 9 to do the same thing. And it's really important that we provide patients access to that, since those products are not currently available within the system. And I know you asked specifically about Marinol, but just a fun fact, Epidiolex, the first FDA approved version of CBD, is $1,000 for 2 ounces, something you can get at your local smoke shop for $10. So, and it's not covered by insurance. So it puts the patients at an odd position whenever they're trying to seek relief. And some of them are sneaking it in anyway. So this law will actually protect the facilities. And I hope that answers your question in regards to Marinol.
Great. I
James
appreciate the
Creel.
opportunity to ask the question, sir. And I am done. Thank you.
Thank you so much, Senator Stone.
Thank you, Mr. Chair, and thank you for the presentation. And Mr. Creel, it's good to see you again. It's been a while. So I've always been a medical marijuana advocate. I've always believed in the pharmacological benefits of cannabis. And I'm speaking as one that is very interested in seeing people get the kind of care that they need, but I just want to make sure we understand that Delta 9 THC is metabolized by the P450 cytochrome system, right? And there are drug interactions, ketoconazole, macrolides, amiodarone, which regulates heart rhythm. So I just want to just counter what I heard. It's innocuous. It's not innocuous. There are drug interactions that a physician should be concerned about. But here's my concern about this bill. We have a federal government that is very supportive. We have state governments. I was supportive in California. I'm supportive here of cannabis being used medicinally for a variety of different things. But you have, federal administrations that come and go. And my worry is that a hospital is the beneficiary of federal funds, Medicare, Medicaid, TRICARE. And I also worry that hospitals have a DEA license, and marijuana is still a Schedule I drug the last time I checked, although I think Congress should get rid of that designation. So my concern is that are we putting our hospitals, maybe not today in harm's way, but are we putting our hospitals in harm's way if we get a president and an administration that takes a reverse position on cannabis and says, no, that's a Schedule I drug, and we're going to go after institutions and people that utilize it. So that's my first concern. I was wondering how you got around that in California in ensuring that these wonderful facilities are not going to get taken down.
Well, Mr. Chairman, if I may field that question to Senator Stone. First, in part, and Senator Dr. Titus brought it up on concerns about funding mechanisms and these for Schedule I drugs being on facilities, et cetera, and what was, I guess, missed in the reply on that, or in part anyway, is that we do have that communication between Ms. Hickey and CMS stating that this was not necessarily a target area of concern. That's what gave them comfort in passing it in California. Also, back in 2013, the very concern that you have, Senator, when I was a member of this legislative body majority leader in the House, in the Assembly, was, what about the feds and what about other administrations, et cetera? But historically, since that time, we have seen both Republican, Democratic administrations come and go, and zero effort has been made in that regard. And I think the reason why that is because, in large part, is that a roadmap was created to say, if you have a robust regulatory system in place and rules and such, then this is not on the Fed's radar screen to do that. They have bigger fish to fry on this. And as medical cannabis becomes more acceptance from, experts like Dr. Titus and yourself start realizing the benefits of this, I think they're seeing this pathway happen, this transition of allowing, particularly here, I think it's a good first step, is only for terminally ill patients to do this. And we have in here these, that's not going to be allowing smoking or inhalation type of consumption of these cannabis products. There are safety measures in here on a lockbox and who's, going to be administered. No physician is going to be prescribing. No nurse practitioner or anyone's going to be coming in and administering it. This is going to be the patient and family members alone. It's just going to be inside the facility. And I think these are the type of protections that will prevent, any administration from saying, you know what, we've got to lock down on this. We've got to go and start prosecuting and taking licenses. I just don't see it happening. I think if this is the process that we are seeing an evolution in the care of patients, and in this first step, it's terminally ill patients.
No, I understand that, and I appreciate that. Did the California legislation include all the veterans hospitals? Are they required by the California legislation to allow for this cannabinoids being brought in by patients, for terminally ill patients?
Senator Stone, I'm uncertain with that question, and maybe Mr. Creel can answer that.
So actually, I would like to bring in my co-producer, Jim Bartell, to elaborate on that, if I may.
Please proceed.
Hi, I actually had a testimony to give today. I was added yesterday as one of the presenters. But I think the question that's being asked right now should be answered by Aaron Hickey.
Please proceed.
Aaron, you didn't.
Yeah, if I can get back to you on that in just a minute. It's been a couple of years since I've been in the legislature, so I just want to double check. But I don't believe that they were.
Yeah, in the interest of time, if you can provide it to us as a follow-up, that would be greatly appreciated. Senator Stone, did you have any other further questions?
I was just going to suggest, obviously a federal facility like a VA would be certainly a shining example that this law is universally accepted, not only in the state, but within the federal bureaucracy, if you will. I know that in Section 2, line 4, I'll read it, except as otherwise provided in this section, in Section 3 of this Act, a medical facility shall allow a patient of the medical facility to engage in the medical use of cannabis at the medical facility. I might suggest that you change the word shall to may, so that, because we do have a veterans hospitals here in Nevada, just to make sure that we cover all of our bases and give a hospital that really might think that this is a risk to say, no, we're just not going to do that at this hospital. And those that are willing to take the risks, and I hope that they do, because I think there's strong benefits for cannabis and terminally ill patients. But I hope that might be something you might consider. And thank you so much.
Thank you, Senator Stone. Any other questions? Let's move to support testimony. So if folks are in support, please come forward, both here and in Las Vegas. And we will begin here in Carson City and then head down to Las Vegas. Ms. Magnus.
Good evening, Chair and members of the committee. For the record, my name is Annette Magnus, and I'm the Executive Director of Battleborn Progress. We strongly support AB 411. This measure is one that seeks to make sure someone who is terminally ill is able to live their last moments of time in a way that is painless and compassionate if they choose to do so. Cannabis has been shown to have potential benefits for patients with terminal illness, including reducing pain, nausea, and vomiting, and improving appetite. For patients who are nearing the end of their lives, these symptoms can be particularly difficult to manage and can significantly affect their quality of life. Medical cannabis can provide a care option that may alleviate some of these symptoms and improve their overall well-being. This would all be done under medical supervision, as the bill states. It is the right thing to do. We have legalized marijuana in this state. Please support AB 411. Thank you for your time.
Thank you so much. Anyone else here in Carson City? Let's go to Las Vegas.
Hello, Julie Montero for the record. I represent IPA and CPR, fully support and are in favor of AB 411. And we did have the sponsors and expert witnesses' testimonies in support of this bill. And if you kind of think about it, this bill will actually be the actual start in integrating medical cannabis into our healthcare systems and allow limited facilities to do so within their demographic. And this only demographic, we're only just talking about end of life, people with 1 year less to live. And it's not all the medical marijuana program patients, but it's a start. And I have to give this into consideration for working with hospitals. This patient demographic will actually be easier for first to integrate and write standard operating procedures and hospital policies, because things are going to need to be written prior to opening the floodgates to all the medical cannabis patients and specialists that we have out there. And you got to remember, too, it's vital that patients are able to secure a continuum of care within the medical medicine of their choice, not what outdated hospital policies or synthetic pharmaceuticals are dictating at this current time. Because, you know, if you think about it, patients really deserve to choose their care and maintain a continuum of care of their choice. And a lot of these patients are coming to the hospitals and being put back onto these harmful IV, heavy end-of-life medicines. And with Ryan, if you guys look back at his story, he was actually able to integrate with his entire family those last 2 weeks. And that's why Jim Bartell, standing right there before you, has such a strong testimony. I hope we get to hear that. With that, we really, really would like to see the medical professionals of the current regulations or benefits, because we want to really avoid social stratification and patient discrimination. Discrimination is something that we see in all walks of life, especially through COVID, that's brought little things out of the thing, but you know, it's the right thing to do. It's compassionate and it's time, and whether the hospitals recognize it or not, your patients are using it. They don't tell you, but I have many of my patients tell me that they're using it. So please, let's let this start to give us a strength to be able to have patients have a right, and thank you for your time.
Thank you so much for your comment. Next speaker, please.
For the record, Jason Greninger, Greninger. Good day, Chairman Dante and members. You all have a peer-reviewed exhibit and link to an amalgam of hundreds of experiments and data on our endogenous cannabinoid system and cannabis. In summary, we humans have an endogenous cannabinoid system that makes 150 endogenous cannabinoid keys. Your body uses these keys to manage equilibriums throughout your body, including diet, sleep, stress, pain, anxiety, sugar, and more. All your cells, membranes, have 37 types of receptors for these cannabinoid keys. Many of you have heard of CB1, CB2 receptor, and that stands for cannabinoid. And these keys are considered retroactive neurotransmitters, and which means they create change from the nucleus outward. And we make our own endogenous THC, and it's called anandamide. Ananda means bliss. Cannabis makes 144 known phytocannabinoids, and they're true mimics of our endogenous keys. Now, only 7 plants are known to make these keys, and most very few. Now, whereas we have much to learn about this plant, we have clear indications for medical need. And it's important in our discussion to remind ourselves why this conversation started. Discoveries like Charlotte's Web, our endogenous cannabinoid system, and the data before you. Whereas our population, our loved ones, are making greater use of these products. And not only are they needed to manage symptoms specific to the illness, they also help manage anxiety and stress related to their care needs. And it's unfair to take that away from our loved ones and from ourselves when we transition to this care, when we need it most. Please support AB 411. Thank you for your time, consideration, and happy to answer any questions you might have. Thank you.
Thank you so much. Let's go to next speaker, please.
Hello, I'm Susan Prophet. And I would like to thank you for bringing this bill to the floor. And thank you, Dr. Titus and Stone, for bringing up the question about the drug interaction. That gives us one more reason why we want to pass this bill, because I believe families are going to bring it regardless. I know I would if I were dying, because I've been a medical marijuana user for the last 6 years, and it basically saved my life and made me healthier. I cannot lay down without taking an edible before going to sleep, or I will not be able to sleep because of nerve pain. And I came here actually earlier today to testify on AJR 8, which is making it a priority to appeal to the federal government to legalize it for medical use. And I can tell that that's just a step closer towards legalizing it altogether. And I hope it is for medical purposes, because it really is a wonderful medication for a lot of problems. And I've noticed that even when you take it, after a while, the cannabinoids don't make you feel high anymore, but you still get the medical benefits. And that's a wonderful thing, especially when you're nauseous. It has come in handy a few times. So again, I thank you for your time and your service.
Thank you, Ms. Prophet. We appreciate your testimony. And is there anyone else in Las Vegas? Oh, we have a couple more folks. Please begin.
Good day. This is PJ Boulanger. I am a certified health educator, certified wellness educator, certified in the JET technique of kinesiology, and I'm also a molecular hydration specialist. I want to let you know I'm 60 years old. I've been battling autoimmune diseases my whole life, along with PTSD and ADHD. So I should really be in an institution somewhere. I've been all natural for the most of my life. I've tried things that were pharmaceutical, and I specifically say that for this very clearly. I do call it pharmaceuticals, and I don't want those in my body. I've survived 2 heart attacks. I'm overcoming goiters and Graves' disease as we speak, healthier than most people in their 30s because I'm all natural. If anyone could show me any other 60-year-old woman that's gone the medical route, the pharmaceutical route, that's doing half as well as I am, I'd love to meet them. My point here is twofold. Please to really consider how cannabis, which they renamed it the slang word marijuana, right? How it became Scheduled 1 drug when it's an herb from the earth. And I would highly recommend that you all go home tonight and watch all 3 episodes of The History of Weed. It's very important that you know that it was deceitfully scheduled, a Schedule 1 drug when it's an herb, not a drug. And it was deceitfully manipulated to be outlawed, and the prohibition is evil. It's been evil. And you take the consideration of how it became a Schedule 1 drug, and we need to push, y'all need to push, we all need to push together, right? We all work together to get it deschedulized so that you don't have these concerns you've been talking about. So simple, right? Let's get it back to where it's supposed to be. It's an herb from the earth. And then secondly,
Thank you so much, ma'am. If you can wrap up your comments, please.
Yes, Marinol is not necessarily safe for everyone because, again, it's a pharmaceutical that could have side effects. And some of us that are all natural don't want synthetics in our bodies. Thank you so much.
Thank you so much. Let's go to the next person, please.
Thank you so much for your time today. My name is Katrie Saunders. I am Vice President of Pardon Me Please and Government Affairs of Legislative Action, and also with Coalition for Patients' Rights. I'm a longtime patient advocate and patient in Las Vegas, Nevada. I've been using medical cannabis for quite some time for my chronic pain, fibromyalgia, nerve damage, and PTSD. I know how important it is for patients to have safe access at the end of their life or just at any point and not be persecuted or criminalized for needing to have this. I support Ryan's law, and I believe that terminally ill patients should have the right to use medical cannabis if they choose to do so. Medical cannabis has been shown to be effective in healing a variety of symptoms associated with terminal illness, including pain, nausea, and vomiting. It can also help to improve appetite, sleep. In addition to medical cannabis can be used to manage anxiety and depression, which are common among terminally ill patients. I understand there are some concerns about the safety of using medical cannabis in a healthcare facility. However, I believe that these concerns can be addressed through the careful planning and implementation. For example, hospitals can develop protocols for safe use of medical cannabis, and they can train staff on how to recognize and manage potential side effects. I believe that Ryan's law would provide a valuable service to terminally ill patients. It would have access to treatment options that would potentially improve their quality of life. I support you guys to urge this legislation. Sincerely, Katrie Saunders. Thank you for your time today.
Vicki Higgins. I'm with Coalition for Patient Rights. I support AB 411 as it is very important for cannabis patients to be able to use their medical cannabis in its many forms of delivery to assist in pain relief and quality of life. If they're treating this at home with cannabis, when they move into a facility, cannabis should be available to them for their quality of life and consistency of care. We feel this is the first step in reintegrating cannabis back into our medical systems where it needs to be. Natural plant-based medicine is the preferred method of many patients and should be integrated into their care plan. I appreciate your time. I say ditto to many of my former speakers, and thank you again.
Thank you so much. Anyone else in Las Vegas? Let's move to virtually in support.
If you would like to testify in support of AB 411, please press star 9 to take your place in the queue.
And before we proceed, I just want to make sure that if there are folks on the Zoom link that would like to testify, they would have to go through the process of calling in virtually, since the Zoom links are reserved for presentations. But please proceed, BPS.
Good evening, Chair and members of the committee. My name is Matthew Wilkie, M-A-T-T-H-E-W-W-I-L-K-I-E, for the record, calling in support of Assembly Bill 411 and its efforts to provide relief to terminally ill patients who choose to use cannabis for medical purposes. By allowing certain medical facilities to allow patients with valid registry identification cards or letters of approval to engage in medical use of cannabis at the facility, this bill helps ensure that patients receive proper care and treatment with a medication that provides them with much needed comfort. Overall, this bill represents a step forward in providing compassionate care for those who need it the most. I urge its swift passage and approval. Thank you so much for your time. And lastly, I want to say thank you, Chair, and all the senators there for running a great meeting. And lastly, I want to thank all the LCB staff who don't really get the recognition that they deserve. So thank you all for your time.
Caller ending in 333, you may unmute and begin.
Caller with the last three digits, 333, please press *6 on your phone to unmute yourself. Once again, caller with the last three digits,
Can you hear me?
333.
Can you hear me? Can you hear me?
Yes, we can hear you.
Thank you. Good afternoon, or good evening, I guess. Reverend Donate and its members. My name is Jim Barksauer. 5 years ago, on March 1st, 2018, my oldest son, Ryan, age 31 at the time, was diagnosed with stage 4 pancreatic cancer. He passed away 7 weeks later, April 21st. The first hospital he was in treated his pain with fentanyl, which put him to sleep 99% of the time. For 4 weeks, I repeatedly tried to have fentanyl replaced with medical cannabis, but was unfortunately unsuccessful in my attempts to do so. After I arranged for him to be transferred to a hospital that allowed medical cannabis as a treatment option, the results were immediate. The nurses stored his medication in a locked area and were shown how to administer the tincture medicine under his tongue. The first morning after beginning medical cannabis, Ryan woke up pain-free and conversant, and was able to spend the last 3 weeks of his life awake and in contact with his family and friends. The happiest day of my life was being present at the birth of my 3 children. The saddest day of my life was watching Ryan take his last breath. After he was passed, I was angry with the first hospital for taking away 4 weeks of his life when they could have otherwise, he could have otherwise been awake and pain-free. This motivated me to spend the next 3 months researching all 50 states to find out what they were doing to regulate the use of medical cannabis in hospitals. There was nothing. So I decided to take the matters in my hands and with the help of attorney Ken Sobray and nurse Manis, they wrote legislation, Ryan's Law, requiring all hospitals to allow similarly ill patients to use medical cannabis for treatment or pain relief. I introduced the bill in California in February 2019, briefed all 120 legislators, including Senator Stone, and testified at all the hearings. In July of that same year, the bill passed unanimously in both houses and was sent to the governor's desk. In September 2019, he vetoed it, as he had been convinced by the California Hospital Association that they would lose Medicare and Medicaid funding if the bill were passed. However, they didn't deter me. I reintroduced the bill in February of 2020. When COVID-19 hit in March, I decided to pull the bill and reintroduce it a year later in February of 2021. This time, once again, it passed 2 vote passes with only 1 no vote. Knowing that COCA would once again attempt to persuade the governor of the negative impact on Medicare and Medicaid funding, we contacted the Center for Medicare and Medicaid Services, provided them with a copy of the bill, the government veto letter, and the opposition letter from the California Hospital Association.
Thank you so much, sir. If you can wrap up your comments, please.
1 minute. Asked them if it was true that hospitals would lose Medicare and Medicaid funding if they use cannabis. Their response was no. They had no regulations prohibiting hospitals from having cannabis, and they would not lose Medicare and Medicaid funding if they did. I sent a copy of the response to the governor and signed Ryan's Law on September 28, 2021. It became law in California on January 1st, 2022. The bill is now being processed in several other states, and it's my ultimate goal to have it adopted in all 50 states, so that millions of families will not be forced to go through what my family went through.
Thank you so much, sir. In the interest of time, we're going to have to go ahead and move on to the next testimony, but I encourage you to please submit your testimony in writing. BPS, is there anyone else virtually?
If you would like to provide testimony, please press star 9 now to take your place in the queue.
I get to proceed?
Please proceed.
Great, thank you. Again, Chair Dunyate and Senators, this is Erin Hickey, testifying in a personal capacity today, but formerly worked for California State Senator Ben Wesso.
I'm
wanted
sorry.
to first
So
address the question of
we want again, I made the clear differentiation before the bill presentation that the presenters cannot be testifying on this bill. There was a clear delineation as to which capacity they were participating. I did allow the parent that had sponsored the bill in California just to share his personal perspective, but we do not want the bill presenters to go back and forth between bill presentation and testifying. So BPS, is there anyone else that would like to provide testimony at this time?
Chair, there are no callers choosing to testify at this time.
Thank you so much. I see someone in Las Vegas. Are you in support, sir?
Yes.
Okay, please proceed. You'll be the last one, and then we'll move on to opposition.
Thank you, Chair. Good evening, Chair and members of the committee. My name is, for the record, once again, Timothy Otto. And I am, so I'm speaking in support of Assembly Bill 411. And I would like to basically echo that, most likely the sentiments of the previous speakers as well. And also like to include that the Nevada Senate recently took a monumental step forward with the approval of SB 239. And with that in mind, I would just like to include that I personally was with a personal story of mine is now I'm 36 years old. At the tender age of 17 years old, I was placed on permanent disability. And for the first time in my life, I contemplated suicide. And that took me on a very long journey in studying everything I could possibly study about on ethnobotany, just to be able to give myself the sort of life that I would always had wanted. So in support of AB 411, I would like to state that I previously had experience when a very good friend of mine was in the process of transitioning from a brain injury condition, disease that he had unfortunately, and during that process, over at the hospice, the parents, if you could imagine what's going through their mind as they're literally, saying goodbye to their beloved son. Just that process was very unbearable. So the mom decided to partake in cannabis. Wanted to
Thank you so
find
much,
your
sir.
way.
Can you please wrap up your comments, please?
So in support of AB 411, I would like to basically state that crucially it's important that we give access for those who are terminally ill to be able to have access to this medicine. Thank you for your time.
Thank you so much. Let's move on to opposition. So if you are opposed to this bill, please come forward now. And we'll ask the same for folks in Las Vegas. Please begin.
Chair Donate, Jesse Wadhams for the record, representing the Nevada Hospital Association. In deference to the hour, I will attempt to be brief. Because you guys have, the senators, you have hit on many of the concerns we have in the Nevada Hospital Association, things like the federal illegality of the drug. I understand we have legalized it recreationally and medicinally in this state. However, we do have a letter, and I think it was submitted to the record. If not, we will get it there. But from the DEA, the United States Department of Justice, to the California Hospital Association, stating that federal law remains illegal. the self-administration of other drugs in the acute care situation. We have concerns there. And with regard to the time to implementation, if enacted, this bill would have to be implemented and operationalized in your hospital facilities in 53 days. And that's just not enough time. So again, and I appreciate Mr. Horn and the proponents giving some consideration to our amendment, and I always look forward to working with my friend and colleague, Mr. Horn, on any way to get to a good bill.
Thank you so much. Please proceed.
Good evening. For the record, my name is Adam Porath, P-O-R-A-T-H. I'm the Vice President of Pharmacy at Renown Health, and I'm representing Nevada Society of Health System Pharmacists. We are in opposition to AB 411 for mainly in the acute care setting, the concerns that Dr. Titus brought up in regards to not allowing patients to self-administer medications within an acute care hospital, let alone bring in their own medications with very rare exception. Senator Stone brought up the drug interactions with cannabinoids. Mr. Krill testified to the potential benefits of the entourage effects with a naturally occurring marijuana product. However, I think that just compounds the potential drug interactions when you have multiple cannabinoids and terpenes in a product, and that we don't really know how that all works today. And so for all of those reasons, I cannot support this in an acute care setting. Thank you.
Thank you so much. Please proceed.
Hello, good evening, committee. My name is Ashley Garza Kennedy. I'm representing Clark County, but here today on behalf of UMC. UMC is opposed to AB 411 because it places our medical providers and our hospital at risk. Cannabis, while legal at the state level, remains an illegal Scheduled I controlled substance at the federal level. This has three consequences for hospitals like UMC. First, medical providers and employees of UMC may be subject to criminal penalties if the bill were to pass. While on its face, the bill does not appear to require UMC clinicians to do anything more than allow a patient to use cannabis. This is not the case. There is no recognized supplier of medicinal cannabis at UMC. Pharmacy staff must therefore verify that the substance provided to the patient is in fact cannabis. Staff would then have to dispense the cannabis to the patient, even though clinicians are prohibited from distributing cannabis in a hospital because it is not approved by the U.S. Food and Drug Administration. Staff involvement in the verification and distribution of a Schedule I controlled substance in this manner could subject them to federal criminal prosecution, while currently, the Department of Justice does not prosecute persons strictly following state laws related to cannabis laws. This policy is not federal law and is subject to change. The second consequence for AB 411 is also severe. UMC is an accredited hospital. Requiring UMC to allow patients to use this Scheduled I controlled substance, it puts that accreditation in question and puts the hospital's federal funding at risk. This is a significant consequence for us at UMC because unlike other hospitals in Southern Nevada, Medicare and Medicare patients account for 2/3 of the patients that visit us at UMC. This loss of income could be devastating for UMC. Lastly, drug interactions are a concern. There are very few studies about drug interactions with THC, so whether a prescribed drug will interact with THC isn't something that is readily known by pharmacists and is not flagged in UMC's drug database software. Sorry, Chair, I'll wrap up. All in all, we think that this AB 411 puts UMC's, could impact potential liability, and for those reasons, we are opposed. Thank you.
Thank you so much. Anyone else in opposition here in Carson City or Las Vegas? And BPS, anyone virtually?
If you would like to testify in opposition to AB 411, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Do we have anyone in neutral for this bill? Seeing none here or in Las Vegas, BPS, anyone virtually?
Chair, there are no callers to provide neutral testimony at this time.
Thank you so much. Mr. Horn, do you have any closing remarks?
Thank you, Chairman, members of the committee, for this final opportunity, and be brief because of the late hour. I will reiterate that first, nothing in this bill calls for a physician, a nurse, or any staff at the hospital to administer or help administer or prescribe cannabis in any way to any of the patients. Simply, patients oftentimes are already utilizing cannabis for their care in their final time. These are for terminally ill patients only. The presenters that we had on Zoom will provide written testimony and send in reiterating that California and I believe also Washington are already utilizing this. As for the fear of federal enforcement, I still stand that I don't believe that administration is going to try to roll back what many states are already doing in the cannabis space at this stage. And they certainly aren't going to start by saying, let's go after these people who are terminally ill and utilizing cannabis for their final time on Earth. I think that that ship has sailed, and I think that they are looking for direction from the states on how to proceed in such matters as end-of-life care in cannabis space, and also in other areas that cannabis is being used. So I think that those fears are misplaced at this time.
Thank you so much. We'll go ahead and close the hearing for this bill, and we will move on to public comment. Is there anyone here or in Las Vegas? And we will go to... Looks like we have someone in Las Vegas. Please proceed.
Good. Sorry. Good evening once more. And just for time sensitivity, I'll be very brief. And for the record, once again, my name is Timothy Eliado. And this time I am speaking as an applicant. I was indeed an applicant for the social equity cannabis lounges that was recently passed. And I'd like to basically state that most recently, CCB Chair Douglas had most recently made a very profound speech on the determination of the CCB stance with the legislature in regards to AB 341, which was indeed to license and regulate cannabis consumption lounges. And unfortunately, quote unquote, by Chair Douglas' words, the legislature failed to put forth a meaningful social equity program, or provided the CCB the authority or the finance to do so. And I wanted to state that, and the reason for this is that, unfortunately, SB 341, with all its good intention, was not executed with good intention. And it has, and that void has left, that void has left entrepreneurs such as myself with a very dark, I'm so sorry, I'm not even sure what words to put it, but it's have lost the, I thought this was supposed to be a democratic process, but unfortunately I have lost all respect for the process in which it was supposed to be stated. And
Thank you so much, sir. You have reached your 2-minute limit, so we'll go ahead and if you can submit that in writing, we would happily take it and refer it to the appropriate channel. Anyone else in Las Vegas? BPS? Anyone virtually?
Chair, the lines are open and working, but there are no callers at this time.
Thank you so much. That concludes the business of today. We'll see everyone on Thursday, and the meeting's now adjourned.